Can everybody hear me? Everybody hear me in the back? Are we good? I think we're going to get started. So welcome to everyone to our 8th annual Parkinson Symposium. We are really, really excited that you guys are here. Welcome to those who are in person here at the venue, but we also have quite a number online, so welcome to them as well. My name is Christopher Tollison. For those who don't know me, I am a movement disorder neurologist here at the Cole Center. I'm also the medical director of the Cole Center. We have a really great program for you guys today. I'd like to quickly run through it. So in the morning, we're going to start out with an introductory lecture on Parkinson's from Dr. Barbu. Then we're going to move into a talk on some of the surgery options in Parkinson's disease from our functional neurosurgeon, Dr. Gerard. And then Dr. Zayas is going to complete our morning with a talk on non-medication therapy options in Parkinson's disease. After lunch, we have our keynote speaker, Dr. Espe, who's going to be giving an interesting talk on looking at some of the interrelated causes that cause Parkinson's disease, trying to argue that Parkinson's is not just a singular disease entity, and kind of how that has ramifications for treatment in the future. This is a really nice segue to my talk, which is a talk on things that are in the research pipeline. Then we're going to end up with something we've never done before. We're going to have a roundtable discussion with some medical professionals and a family with Parkinson's disease, and they're going to talk about some of the hacks that people can do day to day to kind of get through their life with Parkinson's disease. Interspersed throughout the day, we're going to have some exercise sessions, and then we're also going to be serenaded by our music therapy group over lunch. So we're really pleased for that as well. We got a packed agenda. We're very excited about it. None of this happens without a lot of work, and so I have a lot of thank yous to make. First and foremost, Paige Hugler, our outreach coordinator. She did so much to get this going. She deserves a big, big round of applause. She has made my life so much easier, so thank you. I'm not nearly as stressed as I was the last couple of years, so thank you. Big thank you to all the people at the Cole Center that have played a part in this, particularly Laura Clabo. I also want to thank all of our speakers that have put their time and energy into doing this, particularly Dr. Espe, who's traveled to get here. I want to thank the people at the venue who've allowed us to put this on here. I want to thank our AV support system, M3 Technology. Here, Jacob is over there and doing a great job, so thank you to him. Thank you to our catering service, Takeout Thyme. I think we have a good lunch for you guys. So again, a lot of thank yous. Also, I obviously have to mention our sponsors. We could not do any of this without them as well. They make this symposium free for you guys, so we really appreciate them. I want to acknowledge some of our higher level sponsors. So first and foremost, the Cole family, for which we get our name. They've been donating to our center for decades. And not only this symposium, but many of the things we do are supported by them. So a big thank you to them. Then our platinum sponsor is Supernus. Our gold sponsors are Amneal and Kiowa Kirin. And then our silver sponsors are Boston Scientific, Medtronic, and AbbVie. And then we had several sponsors at the bronze level that were very generous to support our symposium as well. Please go to their booths and take a look at some of the things they have to offer for Parkinson's care. So thank you to them to making this free for you guys. I'm going to move into some housekeeping things before I get Dr. Barbu up here to start. So for those who are online, a couple of things. Please refer to the agenda. If you're online, we are going to try as best as possible to stay on time, so you can follow along that way. Laura Clabo, our social worker, will be online, and she will be there for any type of technical support. I also heard that Paige sent out an email at some point, and there's some troubleshooting things on that email, so please refer to that as well. For those of you who are here at the venue, I know many of you may have questions for our lecturers, and this actually applies to those online as well. If you're online, please put your questions in the chat box and put some type of contact information. We will try and get to you either in real time or after the symposium. If you're live, you have multiple options here. There should be paper on the table that you can write down your questions, put your contact information on that. We're hoping that we have time in between lectures to ask or answer questions. We may bring a microphone around if we have time. Also, you're more than welcome to come up to our speakers in between lectures and ask them questions if you have them. And then finally, again, if you have questions, put them on there. We'll try and get to you after the lectures. If you have an email or something like that, we'll try and email you. Feedback forms. These are very, very important for us. We really listen to what you guys say. We want to get better and meet your needs. This year, we're trying something a little different. We have a raffle for a door prize. If you turn in your feedback forms and put some type of contact information on there, you will be entered in the raffle. It's a great prize. I'm not going to tell you what it is, but please turn in the feedback forms. As soon as you turn them in, we will remove your name. We just want to get you in the raffle. They will be completely anonymous. None of the providers will know anything that you say on there. Please be honest. Again, we want to get better. Online, same thing. Please turn in the feedback forms, but have some type of contact information so that we can put you in the raffle. If you don't care about the raffle, just turn in a completely anonymous feedback form. Last thing I have is bathrooms. If you go out into the lobby, take a left and then take a left, it will take you to the bathrooms. You are free to go at any point. You don't have to wait until breaks. We will not be offended if you leave us in mid-lecture. If you get lost, ask one of the Cole people, and we'd be happy to direct you. I think I hit everything. Paige is not looking at me, so I'm good. All right. I'm going to introduce our first speaker. Dr. Barbu is one of our Cole movement disorder neurologists. She's been with us now a couple of years. She is also the neurology head of our DBS program. She is a wonderful clinician. I always tell people that when I open for her. She did her training at my alma mater, actually the Medical College of Georgia, and then she did her residency at the Barrow Clinic in Phoenix and stayed on there to do her fellowship there for movement disorders. So I'm very pleased to introduce Dr. Barbu.
Thank you. I'm gonna go around. Can everyone hear me okay in the back? Thumbs up? Okay, good. I just want to make sure, because I know last year it was hard. Okay. Oh, there's, Dr. Tolleson, is this your phone? I mean, I could keep it. Thank you. Okay. This is my exercise for today. Okay, this here. All right, so I will be giving the kind of overview introduction to Parkinson's disease. So I'm gonna give little snippets of everything, but I will tell you in certain sections where the other physicians will tell you more about it. So we are going to start. Okay, I have nothing to disclose. So I'll be going over the history, the etiology, symptoms of Parkinson's, diagnosis, and treatment options that are out there. Okay, making sure it's syncing with my laptop. So a little bit about history. So Parkinson's disease was described by James Parkinson in 1817 in his essay on the shaking palsy. Now, there were 6 cases in this essay, and about 3 of them were formally examined. But what they noticed was that there were individuals with a resting tremor. They had kind of reduced muscle power in the form of bradykinesia. They had a stooped posture, and they had a festinating gait, which means when you start to walk, your steps get choppier and shorter and faster, and it's almost hard to stop. It's like you have to go head first into something to get yourself to stop. So that's what they noticed in these studies. Let's see, okay. So a little bit about prevalence of Parkinson's disease. So nearly 1 million people in the US are living with Parkinson's disease. And this number is expected to rise to 1.2 million by 2030, and that's just the United States. So that is a lot of people, and there's not enough movement specialists. So if you guys have any kids or grandkids who are interested in becoming doctors, please tell them to become movement specialists. We really need it. And then Parkinson's is the second most common neurodegenerative disease after Alzheimer's disease. And nearly 90,000 people in the US are diagnosed with Parkinson's each year. And I tell my own patients, I swear, I think I diagnose Parkinson's at least 3 times a week, so it's very common. And then the incidence of Parkinson's increases with age, but an estimated 4% of people are diagnosed before age 50, and we call that early onset. And then men, as we know, are more likely to develop Parkinson's than women, 1.5 times. Okay, so what causes Parkinson's disease? So there is an area called the brainstem right here, and it connects your brain to the rest of your body. And all these nerves in your brain go through this area to supply the rest of your body. And in the brainstem, in a particular spot called the substantia nigra, it starts to malfunction and starts to not produce dopamine like it used to. And the dopamine, which is a feel-good chemical that we all know it by, is very important for like coordination, balance, fine motor movement. So when you are losing that production of dopamine, the body's not able to coordinate movement as well as it used to, and you start to notice involuntary movements. But this is not the only area that has a problem in the brain. There are other areas that are involved as well. So if I were to take a tissue sample from someone who had Parkinson's disease in the brain, and I put it under the microscope, this is what I would see. So I would see, oh, cool, okay. You would see Lewy bodies here. Now, Lewy bodies are kind of like a conglomeration of protein that come together and they bundle together. And this protein is called alpha-synuclein. And it's seen in the nerve cells in that tissue sample. And there are many areas that this Lewy body pathology shows up in the brain. And they think it's kind of sort of the end stage of like a complex set of reactions that occur to get to the Lewy bodies. So that's what we see under the microscope. Okay. So normally, let me show you. So as we all get older, we do lose dopamine. It's a normal part of getting older. But in Parkinson's disease, that is accelerated. So that's where the problem lies. And so people start to notice that issue of discoordination, imbalance, when they've already lost 35 to 45% of their dopamine. So that's when you start to notice. Now, motor symptoms are not the only thing people notice. There can be non-motor symptoms as well, which I will talk about a little bit later in my other slides. But the progression of this reduction in dopamine is very different for each people. Granted, it's a slowly progressive disease, but everybody progresses at a different rate and they get different symptoms. Okay. So the biggest risk factor for Parkinson's disease is just getting older, age. But there is a complex interaction between genetics and our environment. So going to genetics first, genetics plays a small role, but there are families out there who have genetic mutations that get passed on, and it's about 20 to 30% of the cause of Parkinson's disease. And we have discovered a lot of genes, but there's still some that we haven't discovered yet, but we have grouped them into autosomal dominant and recessive. So autosomal dominant means that you just need one gene from one parent to have a higher risk of Parkinson's disease. So about 50%. And LRRK2 is one of the common ones that everyone has heard about. But with autosomal recessive, you need one gene from each parent, so a 25% chance. So the risk is a little bit lower with that one. Now, besides genetics, there are things in our environment that protect us. They reduce our risk of Parkinson's disease. And so one is physical activity, which I'm going to talk a lot about and you'll hear more about. The other ones, a lot of studies are coming out showing the benefit of the Mediterranean diet. Not that you have to be a strict Mediterranean, but try to incorporate it more into your diet. Coffee and tea is very beneficial. I drink 1 cup of coffee every morning. Tobacco use, I don't recommend that one, but that is one. NSAIDs, calcium channel blockers, vitamin D. So your calcium channel blocker would be like amlodipine. A lot of people use that for blood pressure. Now, there are things in our environment that increase our risk of Parkinson's disease, and that is pesticides. And in the US, we are very famous for pesticides. We love to use it, and it's pesticides that we use here is actually banned in other countries like in Europe. So it is a big problem here. And then solvents that we've been exposed to from where we lived or what military or where we worked, one being trichloroethylene, these can increase our risk of Parkinson's as well. Air pollution is another one. They're looking into studies of like exhaust from cars, head injury. So if you had a big traumatic brain injury or multiple concussions, can put you at a risk for Parkinson's as well. Okay, so there, I talked about this one last year, but I put it back in. So they're looking at studies between the relationship between the gut and the risk of Parkinson's disease. So if you look at someone who has Parkinson's disease and someone that doesn't, and look at their gut bacteria, it's very different between the two. And they believe that this missed ratio of different kinds of bacteria puts you at risk for Parkinson's disease because it causes inflammation in your gut, and we already have a normal protein in there called synuclein. So when that inflammation occurs, it becomes alpha-synuclein, the one that's famous in Parkinson's disease. And then it hitches a ride on the vagus nerve that is connected to your gut and travels to the brainstem. This is the area I was talking about, that connection between the brain and the rest of your body. And then it starts to spread and increase your risk of Parkinson's disease. So they're doing a lot of studies looking at probiotics, diet, to change that ratio of bacteria in your gut. Okay, so now to the symptoms. So before you get your first motor symptom, people notice some symptoms called premorbid symptoms. And there's symptoms that if I get it, I'm not going to think, oh yeah, I'm going to get Parkinson's in 20 years. But it's some so strong associations that we have seen. So, oh no, too fast. Go back. Okay. So constipation here. So constipation can show up around 20 years before you notice tremor or slowness in your walking. And then REM behavior disorder here. So REM behavior disorder is when you're sleeping at night and you're dreaming, your body's supposed to be paralyzed, but instead you're acting out your dreams. You're talking, you're moving, you're getting up from bed, you're falling out of bed, so people might notice that years before. And then the other one is just excessive daytime sleepiness. You're always tired. And then the other one is hyposmia, and depression can be seen years before too. Hyposmia could be you lost your sense of smell, or it's weakened, so it doesn't have to completely go away. I've heard of cases from others where they got COVID and their smell went away, but instead of getting it back, it never came back. And then they somehow, COVID may have put a stress on the body, then triggered the Parkinson's. So I've seen that happen a lot too. But I put the first symptom as Parkinson's as day 0 here. So you might notice these. So to the motor symptoms, so you might notice a rest tremor. So your hand is like resting on the chair and then all of a sudden you notice it shake. Or you're holding a piece of paper, or you're trying to eat something with a utensil or drink from a cup and you notice your hand shake. So it doesn't have to be a resting tremor. People will also notice slowness. So slowness, how we do in clinic is we have you tap and open and close your hands. And we're looking for like a slowness in the movement, decrement, or like a hesitation in those movements. That's what we're looking for. And the reason why it's important to us because it will affect your fine motor. So trying to tie your buttons, put a thread in a needle, very fine things that you want to do. People also notice stiffness. So they wake up in the morning, granted we all feel stiffer as we get older, but you notice it a little bit more. You also can get stooped posture, as you see over here. When you're talking to someone or not paying attention when you walk, your posture will start to stoop, and then maybe someone will be like, hey, stand up straight, and you'll stand up straight. You may also notice issues with walking as well. So shuffled gait, where the steps are slower and you take smaller steps. You can get freezing of gait. It's when you kind of get into a tight area and your body unconsciously in the back of your mind freaks out and you freeze. You will either get stuck and you can't get that leg to move, or your steps will hesitate and kind of stop midway. That's what people notice. But if you put someone in a big open field, not necessarily a problem because there's not obstacles there for the body to subconsciously be like, oh no, I'm gonna have a hard time with this. You can also notice, because of the shuffling and the balance, you can notice issues with falls as well. Dyskinesias happen a lot later. That's when it's kind of like a dance-like maneuver, and everybody's different. Like some people, they just have it in their foot, so their foot might dance a little bit when they're distracted. Or some people have it very severe where it's the whole body that's dancing as well. You can also see dystonia. So dystonia is like involuntary muscle contractions. Some of the muscles get activated, and they force your hands to do something they don't want to do. So in this case, his fingers are flexing in. Other people might get curling in their toe when they're walking. Some people notice in their neck it wants to tilt to one side or turn in one direction when they're distracted. And we do have treatment for that. We actually do Botox injections to relax the muscles. And then people might also notice motor fluctuations. That's later too. And it happens when the medications you used to take, they used to last great, you know? You never noticed that it would wear off. But all of a sudden, you're noticing they take a little bit to kick in. They're wearing off sooner than they should. So people notice that later too. Now, besides, hold on, let me change this. Okay, I want to show you this video here. This video shows the walking in different stages of Parkinson's. I'm going to look behind me. Okay, so this lady here has slightly reduced arm swing, a little bit of a reduced stride length. Individual here, left hand is not swinging at all, reduced stride length. He's got a little bit of a stooped posture as well. I should point, let me do this. No arm swing here, reduced stride length, slower in his walking. He's got a stooped posture there. And now to mild to moderate stage. That one was a mild that we looked at. So reduced arm swing, stoop posture, shortened stride length, smaller steps, and he's leaning a little bit to the right here. Now, he has to use his hands to stand up. It's difficult to get up, but he's got reduced arm swing, stoop posture, reduced stride length. Now, advanced stage. She also has to use her hands to stand up, stoop posture, absent arm swing, shuffled gait. And it does take her several steps to turn around. She's got a little bit of a tremor there. We call that a gait-activated tremor. So he's able to stand up, but it's slower. It's harder for him. He has to propel himself. He's got a shuffled gait. And this is where you see the freezing. He's trying to turn a corner and he's having a hard time. And it's like his leg's stuck. So she's going to come over and tell him, stop. What you want to do is stop what you're doing, take a moment and tell yourself, pick a foot and say big step in your head and take that first big step to go forward. He had a harder time though. Actually, I don't know if she told him to do that or not. I'm guessing. Okay, so he needs a cane for support, no arm swing, shuffled gait. He needs one person to assist him, no arm swing, stoop posture. And instead of freezing, I'm pretty sure he freezes when he turns, but he's just starting to walk and he's already freezing because this is a narrow hallway. Okay, so that was the motor symptoms. Now, there are non-motor symptoms of Parkinson's disease. So, for example, tremor. Oh, no, I keep clicking the wrong one. Okay. For tremor, for example, here, these are symptoms that you could see. But there's non-motor symptoms under the surface of the water that many times people don't see, and sometimes it's hard to tell. Now, I want to people to keep in mind, you're not going to get all of these symptoms. I've had people that don't have any of them. I've had people that had 1, 5, 2, everyone's different. But the reason I present all this to you is just so you're aware of them. So if you notice them, just to be like, oh, okay, it might be due to that. Now be careful. It is very easy for not ourselves or other physicians to quickly say, yeah, that's a symptom of Parkinson's. So be careful about blaming everything on Parkinson's. Because, for example, someone might have a frequent time going to the bathroom. They're just urinating all the time. They might have trouble with stream, and then they're like, oh, that's Parkinson's. But maybe that person had bladder cancer and they missed it. So just make sure nothing's being missed. Just be careful. Don't always just blame it on Parkinson's disease because sometimes that's not the cause. Now, the different non-motor symptoms you can see are changes in the sleep. So trouble falling asleep, trouble staying asleep, the dream enactment that I talked about, restless legs. So restless legs is like a strange sensation inside your legs. And it doesn't have to be in the legs. It can spread to the arms. And you just have this strange urge to move. And when you move your legs or when you pace at night, you notice some relief. So that's restless legs. You can notice changes in mood, which is a normal part of Parkinson's. Everything could be fine, no issues in your life, but all of a sudden you're just feeling more anxious and you don't know why. So you might notice anxiety, depression. Apathy is like a lack of motivation. You might notice issues with focusing. So when you are in a crowded room and there is multiple things going on, it might make you feel very anxious because it's hard to focus on too many things going on. Or if you're watching TV and your spouse comes by and tells you something, you're just gonna miss both. Like one of them has to shut off for you to focus and understand what they're saying. So they're not trying to ignore you, it's just hard to focus. And then impulse control disorder. This, rare that can happen with itself. It's usually seen when you're on way too much medication, but people might notice they have excessive shopping, excessive gambling, excessive sexual behavior, and they're having a hard time stopping themselves from doing that. And then, bless you, people may also have trouble with just feeling tired, hallucinations. Hallucinations can vary. The mildest form is passage hallucinations. So you see a shadow in the corner, and you look and there's nothing there. So that's the mildest form. And it doesn't bother too many people. They're okay with that. Others can be forms, so you might see bugs, cats, you might see like your dog that had passed away. So some are friendlier and some are harder and scarier to see. So everyone's different. So I don't necessarily treat it unless it's scary and it's really bothering that person. And then the smell we talked about, memory, short-term memory. So you notice like friends you've known for years, you just can't remember their name. You're like, I know who you are, but I can't remember that name. Or your spouse tells you to do something and you forget to do it. Normally, we do selective hearing loss, all of us, but that can happen in Parkinson's as well. And then you might also notice more severe forms of memory would be like, you can't find your way through a route that you've done driving all the time. Or you're walking in your neighborhood and you can't find your way back home. That's severe. And then libido changes, changes in your gut. This is a big one. So people get bloated, constipated. They get full very early. They lose weight. They might get some nausea in the morning, like different gut symptoms people notice. And now Parkinson's also affects your autonomic system. So those are going to be your blood pressure, your bladder. It's going to be your saliva and your sweat patterns. Not that you're going to get all of this, but some people might. So with the blood pressure, there's something called orthostatic hypotension. That means when you change position, your top number of your blood pressure drops by more than 20 points and your bottom by 10 points. And when that drop happens in Parkinson's disease, it's hard for your body to kickstart that back up. So you might feel lightheaded, dizzy. You might lose your balance for a second when you get up. You might feel foggy. Your vision might be blurry or more tunnely, or you feel like something's heavy on your shoulder. And I've seen people where they're walking fine for a couple steps, and then the blood pressure tanks, and all of a sudden, their walking just gets a lot worse. So if you notice these symptoms, like let someone know so they can investigate. And then your saliva. Most people get the excessive saliva, the drooling. There can be some dry mouth. The nice thing about the Parkinson's medications is that one of their side effects is dry mouth, so usually it fixes the problem. But if the saliva is too much, we do Botox injections in the glands here to help. And then sweat patterns, so your sweating can change. So most of the time, people notice in the early mornings of the night that all of a sudden they are sweating profusely from their waist up. Granted, menopause could play a role too, but you can see it in Parkinson's as well. And then bladder can get affected as well. So you have to get up a lot to go to the bathroom. You feel an urge, you have to constantly go. Or sometimes you have accidents as well. So that's going to be the autonomic symptoms. So now that we did symptoms, we are going to go to diagnosis. So Parkinson's is still a clinical diagnosis. I rely heavily on what you tell me and what I see on the exam. So on the exam, you must have that bradykinesia. So when I have you do the finger taps, opening, closing your hands, turning your hands, tapping your foot, I'm looking for that slowness, that decrement, that hesitation for me to be like, okay, there's some bradykinesia here. And then you need to have both or one or the other. So rigidity, not what you feel in terms of stiffness, but what I feel when I'm moving your arms and legs. I'm looking for that resistance to my movement. And then the last one is the rest tremor. So when you have those symptoms, your diagnosis automatically becomes Parkinsonism. It's a vague term. It just means I see something on your exam. But then my job is to figure out, is this atypical Parkinson's? Is this due to a stroke? Is this due to medication? Is this actual Parkinson's disease? So then I gotta look for the cause. So for things that change the diagnosis from Parkinsonism to Parkinson's disease is one, you've got to respond to the medication. So I give you the medication and then I see you back a few months later, and if I see improvement in your scores, because I score them, then I know, okay, they've responded to medication, this confirms it. Or if any point in the disease you start to develop those dyskinesias, that automatically confirms it as well. We do look for red flags. So things that would be red flags to me is that you're progressing way too fast and you are in a wheelchair within 3 years. And in the first year, just starting, you're already falling and losing your balance. It's very unusual for Parkinson's disease. Or you have restriction in your eye movements. That makes me think of atypical Parkinson's like supranuclear palsy. So we do think of these red flags. Now, because we diagnose it based on clinical history and exam, there are tests you can do. Now, these tests are not part of the clinical diagnosis because they're not 100%. But if you feel comfortable, like you want something extra, just to be like, okay, there's something else that supports it, that makes me feel better, that I have Parkinson's disease, you can do that. And we have 3 tests. So one is a DAT scan. This one is not a GI, it's like a tracer that we give IV in your arm. And you do have to sit around the waiting room for around 3 hours because it needs time to travel up, and then you go through the scanner. Now, when you go through the scanner, okay, this is a normal DAT scan. This tracer is looking for dopamine. And if it can't find the dopamine, you'll see a loss on the results. So this is a normal scan. It found the dopamine. There's these nice comma shapes. But here is an abnormal scan. They're smaller than the comma shapes. Or one side may have the comma shape, and this side not as much. So we look for those for a positive test. And now for this test, the sensitivity is 98% and the specificity is 67%. Now the other test we have, hold on, my throat's getting dry. 1 second. Okay. So this is a skin biopsy. The DAT scan is the oldest that we have. The skin biopsy came a lot later after that. But what we do here is we have this tool. I numb the area up. So you shouldn't feel any pain when I take this sample. You just feel a pressure. But we use this bevel device and we turn it until that silver part, like I can't see it anymore. It's in the skin, and then I take it out. And what's interesting, you think I'm taking that much tissue out. It honestly looks like half of it when I show it to you in the test tube. But we take a sample from one side, so you can choose a side, but everything has to be on one side. And we do it behind the shoulder, above the knee, above the ankle, and we send it to a lab in the United States to look for alpha-synuclein in the nerves and the surface of your skin. And so they, based on their presentation, the group who does this at the American Academy of Neurology said they had a 95% sensitivity and a 99% specificity. And so when I get the results, it looks like this. So they show me a picture of what they saw under the microscope. So these are the nerve cells, and the brightly lit areas are the positive alpha-synuclein. And they'll tell me like where they saw it. Was it behind the shoulder, how many they saw, above the knee? So they let me know, and then I know this is a positive test. Now, a newer one that came out, is the alpha-synuclein seeding amplification assay. This is a spinal tap, so a lumbar puncture. And what they do is they have a needle, and they put it in your back between your spine, and they take fluid out, and they're looking for that alpha-synuclein in it. And Dr. Tolson will talk more about this in his slides. But what they noticed when they were first studying this out of 1,100 participants is that the sensitivity was 88%, specificity 96%. These percentages talk about the accuracy of the test. And what was interesting in this test, that the loss of sense of smell was very strongly predictive of a positive test. So like that pre-morbid symptom that I was talking about in the earlier slide. So they noticed 97% had a positive test with the loss of sense of smell compared to 63% whose sense of smell was fine. And then they also noticed the same thing with REM sleep behavior, so that dream enactment. So if you had that, your positive test was going to be 85% of the time. So that was very interesting to see. My dream one day is to see like a blood test for Parkinson's. You do a simple blood sample and it's done. So I'm hoping soon we'll reach that stage too. That'll be a lot easier. Okay. Now, everybody likes to ask me about what stage am I in? And the stage, I can understand. Like, you want to know where you're at, what you should expect, should you be planning for something? It's very difficult to stage because once I give you the treatment, whether it's medication, deep brain stimulation, I change your exam. So it's very hard to accurately score you. But there is one stage, Hoehn-Yahr, and we use it a lot in research purposes. But I'm going to go ahead and just let you know what the stages are so you just know. So stage 1, you have symptoms on one side of your body. Stage 2, you've got symptoms on both sides of your body. Stage 3, both sides, but you're also noticing an issue with balance. You're falling a lot. Stage 4, the person's still able to walk and stand without help, but they do need a cane or a walker for assistance, and they do need a lot of help at home, and they're not safe living by themselves. And then stage 5, the person is wheelchair bound or bed bound. They're not able to get up at all. So that's how we do these stages in research. Okay. I need more water. Dr. Espe and I had great conversations in the car, and I dried my throat out. Okay, so let's say you have been diagnosed with Parkinson's disease. What do you do next? What I always tell people, take time. It's not like you're going to accept it and be like, okay, like overnight, let's do this. It takes time to come to terms. A lot of times it comes as a shock because you weren't expecting it, or you already knew and it just confirmed what your thoughts were. So take your time, reflect on your past, your present, your future. Read a little bit about the disease, get to learn about it, see what your goals are in life, like what do I want to get out of my life, what do I want to do, so that you can choose your treatment to achieve that, because it is possible. And so remember that it's slowly progressive. Granted, everyone's progression is different. There are many treatment options from early stages to later stages in the disease. And then what you want to do is as soon as you're able to come to terms is to get on the bandwagon and start to do something about it, because there are things that you can control. So knowledge is one. Try to learn as much as you can. So you guys already done step 1. You're here to learn about Parkinson's disease. You also want to exercise. Exercise, exactly. Exercise brings a lot of benefits. Like when I see people exercise, I notice their exam is maintained every time I see them. Or I even notice like we meet for the first time and they're exercising and I see them the next time and their scores are already better without me even having to go up on medication. So it makes a huge difference. Nutrition, which I'll be talking about the Mediterranean diet. Not that you have to be strict. I mean, life is short. You still want a cheat day. I have a cheat day, but Mediterranean diet, I'm a huge proponent of, and I do it. Support. So you definitely want to have a support system because, you know, you're going to need help, and you want people to uplift you, to motivate you. You want that support. And then try to have, as best as you can, a positive attitude, because the people that let themselves sink into their anxiety and depression, I've noticed their exam and their whole outlook of Parkinson's is a lot worse. They progress a lot faster. So I'm going to talk about a little bit of each of those components. Okay, so nutrition first. So a lot of studies looking at the Mediterranean diet, it has a lot of benefits. So less red meat and dairy, more seafood, chicken, whole grains, beans, those are really good for you. They've also looked at plant-based diet. They're rich in fiber, so it actually improves your gut ratio and reduces inflammation. Now I added protein in here. So not in the beginning, but later on in Parkinson's, you might notice that your medications don't last as long as they used to. So you want to control when you take your protein so that you can maximize the benefit from your medication. That's when I start talking about it. Now, with protein, you don't want to stop eating protein because protein is very important. You need it for muscles, you need it for strength, you need it for energy. But you want to just time it with the medications when you start to notice the medications are wearing off. So the general rule is to take your levodopa 30 to 60 minutes before or 1 to 2 after a protein meal. So if you're eating crackers, don't worry about it. There's no protein in there. But if you're having peanut butter, banana, chicken, then you kind of want to space it with your medication. Now, here's another thing. A lot of people get nauseated on carbidopa, levodopa. So it's hard for you to not eat anything with that medication. So try to do more carbs, like crackers, something that's not protein to help with the nausea, because you don't want to take it on an empty stomach. And then there's other people, they never get the nausea, so they're fine to do whatever they want. So this is about the protein. Now to the exercise. You're killing me. Okay, so evidence shows that various kinds of exercise may reduce the risk of Parkinson's and have positive impacts on both the motor and non-motor. So like your mood, your sleep, your gut function. So a lot of benefit. And it can improve wearing off and dyskinesia. And the reason is when you push your body, you automatically push your brain cells and nerves to start to do their job better. So that's how it works. And so there was a study to the Parkinson's Outcome Project that showed that people with Parkinson's who start exercising earlier in their disease course for a minimum of 2.5 hours per week experience a slower decline. But honestly, based on my personal experience, it's true at any stage. So keep moving. Now, you ask yourself, okay, exercise, what should I be doing? So variety is always best, and each type of exercise benefits something. Granted, aerobic activity is the best, but you want to keep it variety. So aerobic activity, strength training to keep your muscles, be strong, balance, agility, multitasking, flexibility because of the stiffness in Parkinson's, mind, body. So mind, body is going to be like yoga and meditation. And the reason I think it's important because when you're feeling very anxious or nervous or you don't have good control of your mind, your symptoms automatically come out more. So through mind-body training, you can control that better. Now there's various exercises you can do. So rock steady boxing, everybody has heard about. You can do treadmill training. So you would hold like small dumbbells in your hand. They also sell vests with weights in it. It was a workout. I tried it one time. And then you could do resistance training, yoga for stiffness, Tai Chi for balance. Now, if you live in an area where you're far from a lot of things, then you want to do online. So YouTube always has free exercises that I use. A Parkinson's Foundation has online calendar with exercises, and you can join on the day for the type of exercise you want. And then aqua is great for people who have back and like knee pain because the gravity of land is less in the water, so it's easier to do those exercises. And then there's LSVT Big Physical Therapy. That's a Parkinson-specific physical therapy. They really work on your posture, your arm swing, your steps, and your balance. And then dance. So interestingly enough, a lot of us went to a big movement conference recently in August, and one of the things now it wasn't significantly different, but they just noticed that dance had a slightly higher benefit compared to the other exercises. So I think we should all start taking ballroom dancing or salsa. So think about it. So a lot of benefit there. Okay. So navigating Parkinson's disease. So knowledge is power. Exercise, exercise, exercise. Build your support system. So you want to connect with family, friends, neighbors, join a support group with others who have Parkinson's disease because you can share a lot of knowledge and tips and tricks together that you might have not been able to figure out on your own. And if you got neighbors, you're having a hard time or you fell, you got someone to call to come help you. You also want to build your treatment team. Obviously, you want to move and disorder specialists, but you want to have like the speech therapist that you go to once a year for your voice and swallowing. You want to have your physical therapist for your balance and walking. And then if you do get some of the non-motor symptoms like gut issues, then you want to see a gastroenterologist, bladder issues, a urologist. So you want to build your team based on your symptoms. And then follow a healthy diet. Now, research is big, and Dr. Tollison will talk more about this too, but we want, the more people participate in research, the more and faster we'll get to a cure, because that's my dream one day. And so the research that you can look at if you're interested in doing it is clinicaltrials.gov and Michael J. Fox, and I got their websites right here. Now, for example, if you go to clinicaltrials.gov, on the website, there's an area which you put your diagnosis, you put the city and the state that you live in, and you say how you're willing to drive in a certain rate, like 10 miles, to go to a research study. and it will populate all the research studies in that radius. And then you can look through them, learn about them, see what the criteria is, like, do I meet criteria? And they also have like the email and the phone number of the coordinator that you can message. You'd be like, hey, can you tell me more about this study? I might be interested. And they'll tell you more, then you can see if that's feasible for you or not. So participate in research. Okay. So a little bit of housekeeping to keep in mind. These are important. So studies show that melanoma risk in Parkinson's is higher. So you do want to be careful of skin cancer. Now, regardless whether we have Parkinson's or not, skin cancer is very common as we all get older, so we got to be careful with the sun. So wear a hat, wear sunscreen. But you want to see a dermatologist once a year, and you want to check your skin once a month if you can. So like, I got moles, so I look at my moles once a month, and I want to see if my moles have slightly variation in color. They're not as one color as they should be. And you notice the edges are irregular. They're not as smooth and round as they should be. So that will make you worry, could this be skin cancer or not? And then I would contact my dermatologist, skin doctor, to have them take a look. So look for those variations. Now, the blood pressure we talked about a little bit earlier about orthostatic hypotension. Now, up to 60% of people with Parkinson's can develop this, so this is a lot. And things like if you're dehydrated, if you're losing blood so you're anemic, or your blood pressure medications, these can bring it out and make it worse. So people who've had blood pressure issues like for most of their life, and then all of a sudden, they're getting dizzy and their blood pressure is lower than it used to be. That's very common in Parkinson's. And so what you want to see is if you're starting to feel lightheaded, dizzy when you sit up or stand up, or you're noticing all those other symptoms like the heaviness, the imbalance, let a provider know, because then they can check for your sitting and standing blood pressure and see if you have orthostatic hypotension. And it's possible you don't need those blood pressure medications anymore, and they may slowly take you off of it. So keep an eye out for that. Okay. Now, there are medications that you should avoid or be cautious with in Parkinson's because they can make it worse. So, hold on. Okay. So the antipsychotics, they block dopamine and they can make like tremors, slowness, stiffness, foggy thinking worse. So be careful with these. And some of these people have heard of, like Abilify, Latuda, Risperdal. So be careful with these medications. The ones you guys will run into most are going to be the nausea medications. Because if you go into the ER for like food poisoning, there's a high chance they might give you one of these. So that's going to be Reglan, Compazine, and Phenergan. Those are common ones that people use. There are safe alternatives like Zofran. So if you notice they're giving you one of these, like, whoa, I have Parkinson's, can you give me Zofran? So just keep an eye out for it. And like the Parkinson's Foundation, all them, they do have these lists on their website, so you can show it to other providers. And in the clinic as well, we have a Parkinson's folder, and we put our medications on that list too. Now, these medications you will not see as common. So these are for people who have tardive dyskinesia. They've been on antipsychotics for a long time for like bipolar or very severe depression. And the medication starts to make them have involuntary movements in their lips. They're like moving it or in their head. So they go on these medications to stop that. But the side effects of these medications is a drug-induced Parkinsonism. So I have to keep an eye out for that too. And these, just good to be aware of. I haven't seen anyone on these, but if you're on one of these, just be careful and let your provider know. Okay. So there are national resources for Parkinson's. So these are places where you can learn more about symptoms, research, new things coming out. So you guys have heard of Parkinson's Foundation, Michael J. Fox, Davis Phinney, American Parkinson's, but there's also local resources as well. Okay, so the Cole Center, we ourselves have programs. We have an educational program once a month where we talk about a particular topic. I will be giving my gut lecture again in January, I believe. Yeah, so we pick a topic that month, so if you're interested in a topic, feel free to come. It's free. You learn a lot more. We also have our caregiver group. It's good for caregivers to know what options there are to help their loved ones, to share tips together. So it's a really great session. And then we have therapeutic singing. So not just for a pretty voice, it's to help train your voice because soft voice is very common in Parkinson's. But these have been organized and headed by Paige and Laura, and they've done amazing work. We also have Peterson Foundation, PK Hope is Alive, PJ Parkinson's, Vanderbilt. Now, Black Dog Fitness, not... I'm gonna have to put you somewhere. So Black Dog Fitness, not just exercise, they also have educational events after class as well, where you learn something. So actually, I am doing Women in Parkinson's. I think is it November or December? I can't remember when I'm doing, but I'm doing it soon. So yeah. So we have that, and then there's other local support groups in your packet. If you look in there, there's a list of all the local support groups, where they meet, when they meet, so you can join one. Oh, how much time do I have left? Am I really behind? Uh-oh, let me talk fast. Okay, treatment, really fast. So the goal of treatment is to help with symptoms. It does not slow down progression, remember that. And the treatment is very individualized. I think about your medical history, the medications that you're on, and I pick the one that would serve you the best with the least amount of side effects. So very individualistic. Okay. Now, as time goes on, as I was talking about, people notice the motor fluctuations and the dyskinesia when their medications start to wear off. And that's because as you advance, your body's ability to store and release that medication doesn't work as well as it used to. And you progress too, so there's more symptoms as well. So we've geared medication, lots of them, to try to solve that problem, which I'm going to show you. So these medications stand alone. Levodopa is still gold standard, but these can be given to you by themselves to treat, and levodopa comes in many formulations. Now on this side, we have created medications to treat the wearing off. So we have a lot of options. There's procedures in here too. And then dyskinesia, more procedures than medication. The medication for this is amantadine or Gocovri that helps, but procedures are gonna be the biggest help here for dyskinesia. Really, how much time what time is it? Shoot, we talk fast. Okay, are you gonna, there's gonna be, Dr. Gerard is gonna talk more about procedures. Man, I did it to myself. Okay, so this is Duopa really quick. So this is a cartridge that holds carbidopa, levodopa that goes continuously into the stomach. So it's 12 hours straight of carbidopa, levodopa. So that helps with motor fluctuations and wearing off. And it does have benefits for reducing dyskinesia and troublesome dyskinesia when you're on. The other procedure we have is deep brain stimulation, which Dr. Gerard will talk about more, but it's a surgery, and we don't only use it for Parkinson's. We make 2 openings here, and with the wire under the skin, it goes to a battery pouch here. It's all under the skin. It feels and looks like a pacemaker. And what's cool is I can connect to it wirelessly and send signals to create an electrical field to control tremors, slowness, stiffness, shuffling, dyskinesia, wearing off. So it's pretty cool. But you'll hear more about that from Dr. Gerard. There's also focus ultrasound. So that's a newer one. It's been used for essential tremor a lot more. But you are held still by this device and put in an MRI machine. And with a beam of invisible ultrasound, they burn tissue in the area that we put the deep brain stimulator. And so the bigger the burn, almost kind of like a mini stroke, the better the tremor control. But the bigger the burn, other things run there, so you could get side effects. So people might notice like imbalance, weakness, numbness, tingling. About 6 months later, most of it went away, but like a few percentage, it lingered. And then we have a lot of medications for non-motor symptoms. If you ever need this slide, let me know. So many options. For drooling, we can do Botox to help. Summary. See, I'm doing great. Okay. Each individual is unique when it comes to motor and non-motor symptoms. Build your team. Remember, the medication is for symptoms. It does not slow or stop progression. Exercise is key. But with all your symptoms, you work with a movement specialist to find the ones that work best for you and what you want out of your life. Like, what's your goal? That you want to do photography? We work on treatment to improve that. And I was going to tell you this quote, but I guess you guys can read it. But this was my lovely quote at the end. Thank you. I should have. Say it again.
Thank you so much for that talk. I'm really sorry I sped her up. She had an impossible task talking about Parkinson's in 40 minutes. So, one thing I did want to add on to what she said that I think is interesting that we're doing at UT is she was talking about the concerning medicines. And we have started an initiative to basically in our own hospital at UT Medical Center have those medicines earmarked. So we are trying to make it safer for you guys in the hospital. And as she said, we have materials in our office to try and prevent people from going to the hospital and getting some of these medicines. So I wanted to throw that out there. But thank you again, Dr. Barber. We are going to have a stretch break for just a little bit until 10 o'clock. You can use that to participate in some of our exercise. You can go to the bathroom. If you have questions for Dr. Barber, she's right over there. So the people that will be running our exercise for the next 10 minutes or so are Margaret Keel and Zach Guza. Margaret Keel is a fantastic physical therapist that's at Covenant, and she also works at Zach's gym. She used to work at our own clinic. I can't say enough about her. And then Zach, you already heard yelling at us, so if you want to get worked hard, he will do that to you. But he runs the major Rock Steady boxing group here in Knoxville. So
everybody's leaving. All right, here we go. Wow, that last step's a doozy. Yes, please, I can't see anything. Good morning, 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 morning. Don't leave, don't leave. Stay, it's nice. Thank you very much. All right, good morning, I'm Zach Guzzo with Black Dog Fitness. Oh, and just so we're clear, all right, there we go. Okay, so I'm going to be brief, and then I'll turn it over to someone more serious, Margaret. So, if you can, stand up. So, sitting is the new smoking. It just doesn't smell as bad. All right, here we go. Good, 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 good. Okay, this is going to be really, really, really quick. So, everybody knows that every day starts better with a good vowel movement. All right, stick with me here. Here we go. So what you're going to do, we're going to start out straight in front of you, good long reach, and you're going to open down to an A, and you're going to say A, and then you're going to open out to a T, and you're going to say T, and then we're going to open up to a U, and you're going to say and then an I, and then an O, and we're going to Okay, you ready? From the heart. Here we go. Straight out, let's open down to an A, and you go A, big pull, come back. Out to the T, T, come on, come on, come on, come on, T, back forward. Up to the U for back forward. Up to the Y for Y, big face, come on, big fingers, there we go. Okay, up to the I, and then back to the O. Okay, one more time. Here we go. Now you're good at it. Ready? Then A, big mouth, out to the T, T, fingers, everything, T. Back forward to the U. Here we go. Some of y'all are better at that than others. Here we go. Up to the Y. Y. Up. I, then the O. I. Press it back to O. A little snowing. Woohoo! See? Don't you feel better with a good vowel movement? I probably should rethink that, huh? All right. Something more serious. Let's go over to Margaret. She's a little bit more understandable. Thank you very much. I'm Zach. See ya.
Good morning. I am Margaret, and I'm a physical therapist, and this is Madison, and she's a physical therapist with me as well. So if you're able, stay standing. If not, you may absolutely have a seat, and Madison is going to show the modification in sitting, and we're going to go through some power moves this morning. So since you're stretched out from Zach already, we're going to go through some power moves. So I'm going to put this in my back pocket. So we're going to make big hands, fingers apart. We're going to reach forward really big and then power up, reach, stretch, and then reach forward and power up, One more time, and then we're going to speed up, reach forward, and power up. Now we're going to do 5 a little faster, and since you've done the alphabet with Zach, we're going to count and use numbers. Here we go. 1, 2, 3, 4, and 5. Next, you're going to take your right arm and you're going to reach up or follow Madison. Reach up as far as you can and then come back to the middle, tap, and then you're going to power up to the other side. Reach as far as you can so your weight shifting to one side. And then we're going to go back to your right, reach up, back to the left, and reach up. Now we're going to speed up and we're going to count it. Here we go. 1, 2, 3, 4, and 5. Very good. Now open your arms up to a big T, and you can follow myself or Madison. I think my microphone's coming off with my big movement. Arms big, and then you're going to twist to one side, clasp your hands together, and then open, and then twist, and open, and twist, open, and twist. Now we're going to speed up. Reach big. Here we go. 1, 2, 3, 4, and 5. Very nice. All right, now we're going to step. So if you feel like you're going to lose your balance, please sit down because we are going to step, and you can follow Madison for the seated modification. So you're going to take your right leg, step to the side, turn your toes out, big arms. Then we come back to the middle. We're going to tap down. Then the other way, reach to the middle, back to your right, step and reach, and back to the left, step and reach, and we're going to speed up. Here we go. 1, 2, 3, 4, and 5. Very nice. Okay, you will see these exercises maybe again this afternoon. So, thank you very much. If you have any questions, come find us.
All right, we have one more lecture before an extended break here. Is everybody ready? Okay. I have the great pleasure to introduce Dr. Gerard. He is the head of our functional and neurosurgery program at UT Medical Center. He has been a great addition to our team, and just it's always wonderful to work with a neurosurgeon when you're a neurologist that actually listens to you, and there's always a little competition between neurosurgeons and neurologists, and he's not one of them, so it's been wonderful to get to know him and work with him. So very quickly, in terms of his background, he got his medical degree from the University of Louisville School of Medicine. He completed a residency in neurosurgery at Rush University in Chicago, and then he's done 2 fellowships in functional, stereotactic, and epilepsy neurosurgery. One was at Swedish, and the other was in England, at South Mead Hospital. So we are very pleased to hear him speak, and again, very pleased to have him as part of our team.
Let's check here. Can you all hear me? Is this on? Thank you for having me today. This is not a small group. It's a pleasure to be here to speak with you all. I'm a neurosurgeon, and I'm going on my 3rd year at UT, and thanks for being here and learning with all of us. So I'm going to talk about some of the surgical treatments of Parkinson's disease. Let's see, here we go. I don't have anything to disclose. I'm going to answer two things I want you all to be able to leave with today are some simple things that are not so simple, but kind of big picture. We'll address lots of things here, but we want to make sure that you have an idea of who's the ideal candidate for deep brain stimulation within those patients with Parkinson's disease, and then what are we actually trying to accomplish with Parkinson's disease. So I'll be going through several things, but if at the end of this you all still have any questions, I'll be happy to answer those. So, we're always learning about Parkinson's disease, but we've known about Parkinson's disease for over 200 years. In 2017, it was the 200th anniversary of Dr. James Parkinson. I actually believe he was a surgeon. At the time, surgeons did not go to medical school, so they were misters. And when I was in England, they still called me Mr. Gerard. The real physicians here went to medical school, James Parkinson's described a shaky palsy over 200 years ago, and these are the things we still look for when we see patients. Like Dr. Barbu said, this is a clinical diagnosis. We have things that we can try and use to help us get the diagnosis, but really the diagnosis is key. If we don't have the right diagnosis, we don't know how to counsel the patient, we don't know how to treat the patient, we don't know how to take the next step. So Dr. Parkinson spoke about the resting tremor being even checked by adoption of voluntary motion. At the time, they didn't know about exercise, really. They would say, they would recommend patients to go in a bumpy carriage ride to help their tremor, and that actually did help somewhat. So we've come a little farther since then, but certainly we've learned quite a bit. So the gait, the legs are not raised, and the height in which they will direct, and then also spoke about the non-motor symptoms, and then the bradykinesia and rigidity were described later. So this is something we've known about and has been described for over 200 years, and hence the namesake, but we're always learning. And so Dr. Barbu talked about, we know that there are genetic risk factors that then are influenced by the environment. She spoke about some of those. We know the pathologic, I apologize. I will get this right. We talked about the environmental factors and the genetic risk factors a little bit. We know the pathological findings on autopsy. This is why it's a clinical diagnosis. I would not recommend having a pathologic sample sent from the definitive test. And we know about the neurophysiology, but again, this is a clinical diagnosis, and that's so important when you're talking about treatment. So, surgery for Parkinson's disease has a long, long history. It is something that, has been around for over 100 years. As we said, the initial, as we've known about this for 200 years, the initial pharmacotherapies were almost non-existent. So when patients would develop progressive symptoms and they themselves would be desperate and not have what we are able to offer today, they would become desperate. Without medications, they would look for other treatments, and they would find that the positive symptoms, meaning such as uncontrolled tremor, would be much more bothersome than, say, the negative symptoms, such as the bradykinesia. And so they would seek out a surgeon to make an intervention. And this usually involved making a lesion or intentionally damaging a portion of the brain, and usually that would be the pyramidal system, which is basically your motor system, which allows you to move. And while that would keep you from having a tremor, that would also immobilize you or paralyze you. But that was the trade-off, and that was the advent of neurosurgery. So not a very elegant start in the treatment of Parkinson's disease. As they learn more and more about the neuroanatomy and where to actually make a lesion, here, this is the brainstem, and you can kind of think about this. This is the most concentrated portion, other than in the spinal cord, the most concentrated portion of the motor tracts, kind of like thinking about the wires going into your house at one central area. If you wanted to have a big effect with a small lesion, this is where they would do it. And so the surgeon would come in, make a small window in the skull, and then come in and then do what they call a pedunculotomy here. During one of these surgeries, the surgeon, again, this is almost 100 years ago, avulsed an artery or unintentionally ruptured an artery and aborted the case and waited, and the patient woke up, they were moving everything, and their tremor was gone. So they continued to follow that patient, and they did an autopsy several years later, and what they found was he had injured the anterior choroidal artery unintentionally, and then that had caused a stroke in the globus pallidus internus. Now, that gave us one of the targets for the actual surgery. So as the technology advanced, there was the development of stereotactic neurosurgery or stereotactic frames. And you may, if you've looked at any videos of deep brain stimulation, you'll notice that people are wearing a mask almost, but a very rigid frame. And what that allows the neurosurgeon to do and the team to do is to map out every square millimeter within that box and to know exactly where they are in three-dimensional space. And so what they would do is they would start lesioning this same area that the person had the stroke. The other reason they aborted the procedure where they would go and actually intentionally damage the artery itself is because the vasculature would be very variable. So they would injure that artery, and sometimes it would work, and sometimes the person would have a much worse stroke. So that's why that was abandoned. But now they had a target. So the globus pallidus internus was the target for a lesion, which was the pallidotomy. So that you may have heard of. That continued to be a target, and what they would find was in attempting to hit this target, they'd also unintentionally get very good results for tremor alone when they damaged the thalamus. So we're standing on, the surgeons, such as myself, are standing on the shoulders of giants, not just the surgeons, but the patients that went through this and that we've learned from, and that allow us to offer a more refined technique and targeting. So those were the two targets for the longest time, the globus pallidus internus and the thalamus, or the ventral internal medialis nucleus here, the VIM. So pallidotomy and thalamotomy were the two mainstays for the longest time. I'm sure you all have witnessed the development, or maybe you've seen the movie Awakenings, with the development of L-DOPA and the miracle that has been for patients and offering them the chance to get back to their lives and to improve their symptoms without having to undergo surgery. So surgery went away for a while. At least stereotactic and functional neurosurgery took a hiatus because there was something much better. And I would certainly rather take a medication and have an improvement than to undergo something that at the time was certainly more uncertain. So as the development of levodopa progressed, surgery went away, but then as patients lived longer, eventually those symptoms came back. So there was a resurgence of interest in stereotactic surgery in the 80s and 90s, and then that would lead us to the new area, or the modern area, which is deep brain stimulation. Now we'll talk a little bit about going back into the lesioning with focused ultrasound. So I would say that we're in the modern era, but I'm sure that everyone in history has said they're in the modern era. But so where are we now? So if you look here, these are just a list of publications from PubMed about what therapies and what people were publishing on. So you can see here, the red is deep brain stimulation. This is when, interest, and you can see the blue is thalamotomy, pallidotomy, and those, remember, that's where you're actually causing a lesion, okay? And that would be done with the same frame, but either placing a probe and heating it up at the end, or injecting a high concentration of alcohol. And so as deep brain stimulation became more and more popular, the lesioning went away, at least until, this is 2015, and we're going to talk, Dr. Barbu talked about focused ultrasound, which is lesioning, which we'll talk about, which was FDA approved in 2016. But certainly by far the most common surgery for patients with Parkinson's disease is going to be deep brain stimulation, without a question. So placing wires in the brain to influence symptoms and the neurophysiology is not new. It's been done. It was initially done by a female Russian neurosurgeon, really in the 50s, described it, and that was used for pain. We talked about the development. Oh, I'm really going to get this eventually. We talked about the development of L-DOPA and how that put surgery on the back burner, as it should have. And then the research, one of the pioneers in deep brain stimulation, and really described the technique for movement disorders, which is Parkinson's disease, essential tremor, dystonia, was Dr. Benabid and Pollock. These are French neurosurgeon and neurologists who described it for VIM. And what they were doing was they were still lesioning at that time, but before they would do a lesion, they would place a wire and then with electrodes at the tip, and then turn on and give electricity to the area around the electrode. And that way they would try and find out where the right place to actually cause the lesion or a small stroke. And they found that the patients actually did well and tolerated having the wire in, the electrode, and they could change it over time. So this is how we now use this commonly and perform this surgery on a daily basis in the country. By basically, it was a trial to find out where to cause a lesion. So that's how it started. So, and then finally, the newest target, or not newest, but rather part of the mainstay of deep brain stimulation for patients with Parkinson's is another target called the subthalamic nucleus, or STN, okay? So we'll talk, right now, there are 3 targets for Parkinson's disease. There's the subthalamic nucleus and the globus pallidus internus. We'll talk about the symptoms that those improve in general, but those are the ones that we use commonly, whereas the VIM, it really only improves tremor. So there's a subset of patients that may pursue that, have that as a target, but really it's the globus pallidus internus and subthalamic nucleus, which we'll talk about. So who can it help? So we've talked about, and I've talked about ad nauseum, you have to have Parkinson's disease. And why do you have to have Parkinson's disease? Is because anything else, either Parkinson's plus or Parkinsonism, or some of the things, those patients, not only would they not benefit from the surgery, but potentially we can make those patients much worse. So if you're thinking about pursuing this, you really need to have a confirmed diagnosis of Parkinson's disease. And this is something that if you do pursue any sort of surgical intervention, you want to make sure that you're doing this as part of a team, because this is the most important part of any consideration, is having the right diagnosis. Because without the right diagnosis, everything else that is said or anyone else's experience is not relevant. So those patients, we strive, and if there's any question, we do everything possible to confirm that diagnosis, because those other patients we're putting in harm's way. So a diagnosis of Parkinson's disease, and then the patients that actually respond to dopamine replacement and now are having side effects. So early surgery is certainly a consideration in some patients, but if you're doing very well on your medications and on your routine, right now, it doesn't make a lot of sense to pursue surgical intervention and to then have yourself exposed to that risk. But those patients that have benefited and now are starting to have more motor fluctuations and more off time, those patients are certainly candidates potentially. We want to make sure that patients don't have notable neurocognitive issues. Certainly that is part of Parkinson's as it progresses, but there are scenarios where we can make that worse with surgery. And so all patients that we're considering to undergo surgery or may be candidates, a neuropsychological evaluation is part of that to ensure that we know exactly where people are and we can counsel them about how to pursue that. And then absence of untreated depression and anxiety, that's not necessarily, again, we want to make sure that people are in the ideal state to benefit from the surgery. Some of the targets, such as the subthalamic nucleus especially, can we believe that potentially surgery itself or withdrawal of the medications can make those either depression, anxiety, impulsivity worse. And so again, we want to make sure that we've done everything possible to ensure a successful outcome. So those are the things we're looking for, okay? We want to know with as much certainty as possible that the patient does indeed have Parkinson's, that they've responded to L-DOPA in the past, and now they're having worsening motor fluctuations. Typically, we'll say we want people to have a 30% improvement between their on and off, and then absence of dementia, and then we want to make sure that we've done everything possible to treat any depression or anxiety that's there, okay? How does it work? Well, we don't know, and that's honest. We know it works, but we don't exactly know how. We thought that we were creating a reversible lesion effect, and we are, but also there's data to show we're actually promoting some signals and decreasing other signals. And so this is the thing about what we're talking about. The standing on the shoulders of giants, had people not known that it worked and you went and said, hey, went to the FDA or your own internal review board and asked to do an experiment where you had no idea how it worked, but you wanted to do a surgical trial, people would, they wouldn't let you do that, rightly so. But we do know it works. The actual neurophysiology we think that certainly it promotes, it inhibits some signals and some of the neurons while inhibiting others. But we know we have multiple prospective, retrospective, randomized controlled trials to show that it works. And what is the goal? The goal is we used to say, I can remember in residency in 2010 being in clinic and being with my attending, and we'd go through each symptom and we'd say, this is the data on tremor, this is the data on bradykinesia, this is the data. But really, the way to think about it is your motor symptoms that improve with your medications at your best are very likely to improve with surgery. And so what we want to do is we want to improve your on times, decrease your off times. So the surgery is not stopping progression, but we're turning back the clock somewhat as far as your motor fluctuations. We're trying to stretch the good time out is what we're doing. Get you back to your life, okay? And yelling, and no one's yelled at me yet. Anyway with the exercise, but we want to get you out where you're doing whatever you want to do. So what are the risks? There are certainly some risks with surgery, no question. Having the worst thing, when I see my patients in clinic to discuss this with them, the worst thing that could happen is when that I am in surgery and I'm placing this electrode, remember, and we're going to go through the actual surgery here shortly, is that I were to cause bleeding. If it were significant bleeding, it could be like having a serious stroke or even life-threatening. The chance of having a symptomatic bleed, not just, say, seeing a little bit of blood around your electrode after surgery on the CT scan, but a symptomatic bleed is a little less than 1 in 1,000, but it's not 0. And if it happens to you, it doesn't matter what the odds are. But some of the hemorrhage risk is certainly there's a slightly higher risk of hemorrhage using a technique we'll talk about, use microelectrode recording, where you're listening to each cell and using a sharp needle to define where you are neurophysiologically. You can, and then blood pressure control helps reduce that. Again, the risk of that, asymptomatic, meaning having some sort of deficit after, is about, 0.1%, but it's not 0, okay? Other things that can happen would be things like infection. I'm proud of our infection rate is lower than that at UT, but it's not 0 either. I've never seen a patient hurt by an infection, but if you have an infection, you have to remove the device. And that's very discouraging for the patient, for the team. You've been through all that. I would also say that every patient I've ever seen that had an infection always had it reimplanted because they were benefiting from that intervention. So that is something like any implant, whether it's you're having a knee or a shoulder done, that we have to be vigilant about. But probably, those rates look those are national rates. I would quote you a rate of about 1%, but again, not zero. Other things would be just general neurosurgical risks anytime you're operating around the brain, such as seizure, hardware malfunction. Again, it can happen earlier, especially with patients with significant dystonia or a lot of dyskinesias. Those were more prevalent about a decade ago. The hardware has improved in general, and while things can certainly happen, it's rare. And then stimulation side effects such as motor. Cognitive, certainly some of the data has shown that there certainly can be a cognitive decline. If we look at it, the one in large series is that certainly speech fluency can be decreased after subthalamic nucleus placement. But again, part of your neuropsychological workup is to define who may it be at increased risk and then tailor that surgery to that patient. And then we talked a little bit about balance. If some of the other things, if there's concerns and we have patients that say look to be at high risk or maybe a little older within the patient group, we would recommend staging the surgery, meaning a unilateral lead and then coming back, and patients tend to tolerate that better. But those are the risks. So how do we actually do it? We talked about that frame earlier. There are multiple types of frames and ways to get the electrode where you need it here. So this is the Lexell frame. This is invented by Lars Lexell, a Swedish neurosurgeon, almost 100 years ago. So still very powerful tools. This is what they used to have to do, a pneumoencephalogram or ventriculogram here. We do not have to do that anymore. Our imaging has gotten much, much better. We can actually see the targets now. They used to use basically this to map out the ventricles and then use indirect measurements off of atlases where to place the electrode. So now we can actually see where we want to go, and we can actually plan it this way. So rapid advances, even in my short 15-year career, this has changed dramatically. What this allows us to do is certainly this patient, you can see there's no endotracheal tube here. This patient is awake. They're doing microelectrode recording and then doing what we call macro stimulation, which we'll talk about, or not. There we go. Where we actually turn on the electrode and you see we're checking for tremor. We're listening for cell signals. Now, with at least in our practice here at UT and most centers are moving this way because we can actually see our targets. You get to be completely asleep. So you're under general anesthesia the whole time. It's easier on you, it's easier on us, and that's what I would want. And this has really been the revolution of better imaging and better understanding of the anatomy and the outcomes. So, why do we kind of go through all the iterations of the imaging, and why would we keep somebody awake in the operating room? That doesn't seem like, a great idea. The reason that we did this initially is we know that millimeters matter. These are very small targets. The subthalamic nucleus is a little smaller than an almond, and really there's only a few millimeters within that target where we actually want to put the electrode to get an excellent outcome. So millimeters matter here. This was a paper from UCSF where they looked at electrodes of patients that didn't respond and looked at the distances. And again, this is the actual surgery here is we have very small targets, but now, again, with the ability to image those and to actually see where we want to place these, this has gotten to be a much more routine and tolerable exercise for the patient. So this is a little what we talked about, the different ways to do it. Depending on what center you go to, they may still believe that microelectrode recording is the best way to get an excellent outcome for their patients. So this is where you're placing a very small needle and listening to all the signals here. And you can see here, these are the different firing patterns of the neurons. This is no firing here. This is white matter. And then you're going through the thalamus. And then each one has a very distinct pattern. And you can see here, we still do some awake, but not for our Parkinson's patients. For our essential tremor patients, we still have them awake in the operating room, and they tolerate it very well. And then finally, we always image the patient in the operating room to make sure our electrodes are in the right place. If we need to move them, we move them at that time. And so, again, we know that millimeters matter, and if any corrections need to be done, that's all done at that time in the operating room. So, again, this has changed dramatically even in the last 15 years as far as technique, but also as far as philosophy about, what you actually need to do to accomplish what the patient needs. So, again, what we talked about, multiple different ways to do this. You can do this. This is an intraoperative CT. An O-arm here, this is a robotic arm that can be used. You can do these with actual MRI. The MRI placement here, rather, most of that was pioneered at UCSF, and I know that Emory is a very big advocate of this technique. But again, if you're looking at having this done, I'd recommend certainly having it done at a center that routinely does it, and then also that intraoperative imaging is part of their technique, whatever that image modality may be. So directional leads, again, this has been a very exciting time. One company was making leads for almost 20 years, where we have the actual contacts here with standard 4 electrodes that certainly allowed you to stimulate, but if you look here, I'm not sure if you guys can see it back there, but you get bleed over into other structures that can cause side effects. Now, with directional leads, we're able to shape the actual amount of electricity or the charge, and then avoid. It doesn't allow you to necessarily treat more tissue, but you can push therapy away from areas where you're going to have side effects. So, and these are future iterations potentially where you can even do that even more. But this is a standard directional lead that now all the companies offer, where you're able to, you have 8 different contacts, and you can push therapy away from areas in the brain that are going to cause side effects, such as the motor system, what we talked about, which would be pulling or cause speech problems. So again, this is something that just came out in 2016, I think was the first one. So a very exciting time, and no change really for 20 years before that. So a very exciting time as far as what's possibly being offered. What's the future? Well, one of the things that certainly we're excited about is closed loop stimulation. A closed loop is where you have a device that's actually sensing some sort of biomarker. This has been very successful in treating epilepsy. We have it somewhat in the deep brain or in the movement disorder community. We haven't quite gotten to where it's therapeutic per se, but certainly closed loop stimulation is where you have a device like a pacemaker, senses your heart, and when it detects an abnormal rhythm, will give you therapy. Same thing for deep brain stimulation, where you're sensing a biomarker and then adjusting therapy. That's very exciting because patients, their symptoms will fluctuate, and over time, their symptoms may progress. And so having a closed-loop system that does that, this is already on the market. We're still working out how to actually, while we can see efficacy and change programming, it's not responding to that. So this is in development. It's part of practice, and so this is on the horizon. We talked about those electrodes as far as having more and more contacts and being able to be more selective in the tissue that you're actually influencing. And finally, these are 1.7 millimeter electrodes, and then the actual generators maybe about the third of a size of an iPhone. But it'd be great if it was even smaller. So smaller would always be better, and so that's on the horizon. But certainly, as far as I'm aware, there's nothing coming out that's revolutionary in the next few years. So, but certainly an exciting time. Focused ultrasound. So Dr. Barbu talked about this. This is, again, the lesioning that we talked about. This is a picture from the 50s. So ultrasound has been used for a long time. This is the initial. This was at the University of Illinois. And this is, if you look here, you have 4 different ultrasound arrays, which can then produce and distribute energy by sound waves, and then can cause a lesion. Again, this is something that was in the research realm for a long time, and really they would try to use it to treat brain tumors and other things, but in order to actually get the energy through the skull, they couldn't really do that, and they couldn't really tell when they'd given a successful therapy. Well, but again, very exciting time. With the advent of MR thermography, meaning in an MR scanner, we can actually look, and in real time we can tell what temperature we're getting a very small area to, and having much better ultrasound arrays. Here, this, I believe it's over 200 different arrays. We can then use this like a magnifying glass. Will focus light to a single point, and that's where the energy will meet. And then we can use that to then make a very small lesion, discrete lesion. And here you can see on the left side there, this is a patient that had had a thalamotomy for essential tremor, potentially tremor-predominant Parkinson's. And this is something that certainly is in common practice and becoming more and more common, especially for essential tremor. And we'll talk about, at least for Parkinson's disease, it's something that, again, has good data to show that it has improved patients that are tremor predominant. And but if you recall, this is the same thing we were doing 50 years ago in causing a lesion. If you see the ads for this, they'll say that it's non-invasive. I would disagree with that. It is invasive. You're causing a lesion. It may be non-incisionless, in that you come in, we shave your head, and because your head has to be in a water bath to actually get the energy and through the medium from the target from the sonicator to the target. But at least for the Parkinson's community, Parkinson's is, while not initially, becomes bilateral, and what we're having here, a thalamotomy, that doesn't treat the additional symptoms. It is approved for pallidotomies, but not, and there's certainly research ongoing, a little more in Europe, to do pallidotomies and lesions in the subthalamic nucleus. But again, I would say that we're going back to lesions, and there was a reason, and a lot of that was speech problems and cognitive problems is why people went away from bilateral lesions in the past. So again, something on the horizon. It may be an option for you if you say we're tremor predominant, and or this may have value to individuals that say, I never ever want an incision of that sort. And that would be reasonable for the individual, and it might have value for you there. But I would say as a mainstay of treatments of surgery for Parkinson's, it's not quite there. It's not quite there. But still learning a lot, and there's still many trials going on right now. There's certainly other surgical trials. Again, we talked a little bit, there's a DAT scan about, the treatments that we're talking about, such as deep brain stimulation and any lesioning. We're treating the symptoms. The holy grail here is to actually either stop the progression of dopamine loss, or to replace that. One therapy is glial-derived. There's growth factors within the brain that we know from animal models have stopped the loss of dopamine, or even created more dopaminergic cells. And so that would be ideal, because all of our other interventions, whether deep brain stimulation or lesions with ultrasound, we're just treating symptoms. We're not stopping the progression. So there is research to either, these are small catheters that are placed within the brain and then infused with growth or glial-derived neurotrophic factor to try and stop that and to try and regrow that. again, there's lots of research on this. None of this is prime time, but lots of hope and lots of interest. Other things would be things like gene therapy, where we're actually giving you viruses to then alter the production of these growth factors that then would stop loss of dopaminergic cells. So that's the Holy Grail, to actually stop progression rather than to just treat the symptoms. So again, just to be clear, some I would describe, probably deep brain stimulation. We've been doing it, FDA approved, for over 20 years. It's something that we know a whole lot about. We have a lot of experience and knowledge. Some of the lesioning here, I would say we're probably on this earlier stage, especially in the Parkinson's community and treating those illnesses. But certainly a lot of experience and a lot of hope. Great. Thank you so much for having me. Hey, thanks. Turn this off. 60? 60. Yeah.
Thank you, Dr. Gerard, for a great talk. We're going to have a break. I did want to say a couple things about our program. We have a pretty thriving DBS program right now. We have been doing DBS here at UT for a little over 2 years, I believe, and I just asked Dr. Gerard how many patients we have. We have 60 patients, and I would say that our outcomes are really, really good. And as I mentioned earlier when I was introducing Dr. Gerard, this is a team approach. In terms of process, you have to see the neurologist first, and we make that diagnosis of Parkinson's disease. And then on discussions with your neurologist, if both you guys and we think the therapy is a good idea, then you go through our DBS preoperative process where we do some testing. Then we talk about you as a group. So all the neurologists weigh in, the physical therapists that look at you, the neuropsychologists that check your thinking, and the surgeon weigh in. And we decide whether or not we think you're really a good candidate for it. We hold that conference once a month on a Friday. And then Dr. Gerard puts in the leads if you move forward. And then, again, I'm going to keep saying team approach. We're only as good as the leads. And Dr. Gerard has done a fantastic job with putting the leads where they're supposed to go. So as he said in his talk, millimeters matter, and he's done a great job with that. And then you guys come back to the neurologist, and the neurologist is the one that programs your device. And so again, we've had good outcomes. This has been a really successful program so far. As Dr. Gerard said, you certainly don't need to come to UT, but we would definitely encourage you going to a big center who does it a lot, who also has a good team. The other thing I would mention is MRI guided focused ultrasound is very exciting. Unfortunately, we do not offer that currently at UT. We've been in discussions, but we have not moved forward with that. So if that is something you are interested in, when you talk to your neurologist, we typically send people to centers nearby. So we send to Emory. There's a group in Charlotte. There's also a group in Memphis that we will send to. So we are doing these therapies either here locally or sending people to other places. So if that's of interest to you, please talk to your treating neurologist. So with that being said, we're going to take a break for 20 minutes. We're going to restart at 11 o'clock. So feel free to talk to Dr. Gerard or one of us if you have any questions. All right. I have the pleasure to introduce the last colon neurologist besides myself. This is Dr. Zayas, who's also been with us for a couple of years. He is the head of our outreach. So if you've heard one of us talk, it's likely him. I know he does a wonderful job in the community giving different presentations on Parkinson's disease. So we've been very pleased to have him at the Cole Center. He has had a lot of stops in terms of his training, and I'm going to try and highlight some of them. He was actually initially trained as a physical therapist in Puerto Rico, and then did his medical training in the Dominican Republic. He was initially boarded in internal medicine, and he trained at St. Barnabas Hospital in the Bronx. He then moved on to a neurology residency in Cooper University Hospital in Camden, New Jersey. And then he's actually done a couple of different fellowships. He did a fellowship in neurocritical care at the Cleveland Clinic in Ohio before doing a movement fellowship in Nebraska. So we, again, have been very pleased to have him, and I think he's going to give you a good presentation. So,
Do you guys hear me on the back? Yes, good. Perfect. Good morning. A lot of people here. Oh, I think we have more people today than last year. It is great to see so many familiar faces here. This is great. Thank you very much for coming. So, Dr. Gerald already talked about surgery. Now is my time to talk about non-medication treatment option for Parkinson's disease. This is a huge topic, but I will try. I have to be careful here. I will try to do this in less than 40 minutes, okay? And don't worry about taking notes because this is going to be available for you to watch later, okay? So you will see a few things here. Don't worry, you will have the chance to see that later on. All our presentation will be available online, okay? Let's see how it works. Oh, here it is. Okay, so let's start by saying that we have multiple weapons to treat Parkinson's disease. Or what we think is Parkinson's disease, because that's another question. This is our weapons. We, clinicians, spend most of the time during the first three. The oral medication, regulated by FDA, the surgical treatment, education, and counseling. Today we are going to talk about what I rarely talk in the clinic, maybe because I don't have enough time or I'm not asked. I'm talking about nutrition and supplements, a very common thing. And we will answer two main questions. Question number one, is there any specific diet for Parkinson? And whatever I'm going to talk here applies to everybody with Parkinson or without Parkinson, doesn't matter. And the second question is, what is the evidence for supplements in the setting of Parkinson's disease? I am pretty sure that the majority of you want to have a long, healthy life, right? Maybe that's why you are here, to try to learn something. Let me tell you something. Every time that I meet somebody over 90, healthy, I ask the following. I always this question. What is the secret? What are you guys doing? I want to know. I want to get there too. So I will tell you what I found during all these years. I'm close to 50, 48. Asking the same question to these people. So they always tell me that they don't smoke. That's number one. Number two, they are always happy. They find a way to be happy, to have a positive mindset. They have a purpose. They have always something to do the next morning, even taking the grandkids to the school or taking the dog out. I have an old lady a few years ago, 105 years. I was treating her for trigeminal neuralgia, which is a pain here in the face. And she always talked about her chickens. Every morning, she wakes up to feed the chickens. She has a purpose. That's an important thing. Number three, they are physically active. They're doing exercises, some type of exercise, it doesn't matter. And number four, and the last one, they are not obese, okay? They are not obese, so they eat well. The question is, what is eating well? That's the question. And that depends on many factors like your culture, your background, conditions. There are many things. Now, whether you have Parkinson's disease or not, there are a few things that you can change in your life. It's the way that you, no, still, I'm okay. No, it's okay. Yeah. The way that you, basically, there are two things that you can change in life. The way that you eat, things that you eat, and the exercises. The exercises. So, because if you are going to get Parkinson, you are going to get Parkinson. But this is the things that you can manipulate, what you eat. And unfortunately, I'm not going to talk about exercises. You guys are tired of me talking about exercises. Yes, I'm always talking about exercises. I'm going to talk about diet, nutrition. And yes, exercises is very important, and it's not fun. It's painful. I do it. I do it almost every day, but it's not something fun. I prefer to eat. That's me. I don't know you guys, but I prefer to eat. And the thing is, it gets more complex because you need to have consistency, right, in whatever you do. And people with Parkinson, they have something that we call apathy, which is lack of motivation. Very difficult. And then, if you want something to improve your motivation, to decrease the apathy, I would recommend, I think, getting a dog is the best thing, okay? The only thing is you have to be careful what type of dog. And there is a reason why the dog is called the best friend. There is a reason for that. So you will realize that I am a dog lover. Do we have a dog here today or no? Is here? Okay. Where's the dog? Oh, he's sleeping. Okay. So, I will tell you, some experts recommend a small dog. No, I don't think so. So, be careful with that, okay? Be careful with that. I disagree with that. And you go online, you will find all these things, that small dogs. No. Why? Because you can trip over. And believe me, through all these years, every time that somebody falls, I ask, what happened? Oh, I tripped over my dog. Okay? The leash. And it's always a small dog because we think that small dogs are safer, but it's not. Okay? So be careful with the small dogs. That's my point. Okay? Now, if you ask me what type of dog I would recommend, okay, I would recommend a calm dog, okay? Calm dog. Make sure it's not a working line. It has to be a show line. Otherwise, you'll be in trouble. This is the type of dog that I like. Why? Because they are not too big, not too small. They are smart. They learn very quick. So the lab. Now, avoid these type of hyperactive dogs. So this is my dog. You don't want this dog in your house. Okay? This is my German Shepherd, by the way. She weighs 120 pounds. I'm very proud of him. But this is not a dog for you. It's just too dangerous. Yeah. Now let's talk about the two questions, right? Is there any specific diet for Parkinson? Maybe. Maybe. The short answer is maybe. There is no magic food for Parkinson. There is no magic food for Parkinson. However, we know how good is nutrition to improve our function, our life. Some people say that you are what you eat, and probably it's true. You are what you eat. There are other factors, but you are what you eat. And remember, the diet, a good diet for Parkinson might be a good diet also for your heart too. Nevertheless, we have some data in the setting of Parkinson's disease. So this article was published in 2021. This is an observational study. And this is in Canada. 167 patients with Parkinson's disease. And they found that if you follow MIND diet and the Mediterranean diet, but more the MIND diet, is it more likely there is association. You have a delay in the onset of PD, especially females. I don't know why. Females. Nobody knows. So, but this is the association. And this is the best evidence that we have available, unfortunately, so far. But probably we have a lot of recall bias here, right? But this is not good in terms of the evidence that we have, but it's the best that we have. And the majority of the studies in dietary research are like that. This is the type of diet I would recommend, the MIND diet. And I will talk about what is that, because it's easy to follow. It's not too painful. I have enough pain with the exercises. It's too painful. I was in the track yesterday or the day before, and I was running a 5K to see how I'm doing. I almost died. Well, but so the important thing about this diet is just follow what they recommend. There are 10 types of food that they encourage you to eat, and we will talk about that, and try to avoid or limit the 5 types of food that you should limit or avoid. Okay? That's the main thing. Now, what is the MIND diet? So MIND diet stands for Mediterranean Dutch Intervention for Neurodegenerative Delay. So it's basically combined 2 elements of 2 popular diets, the Mediterranean diet and Dutch diet. The Mediterranean diet is very, very, very similar, very similar. The only thing is the MIND diet encourages more berries, a lot of berries, and nuts. And minimize the other fruits, potatoes, and milk. I'm talking about the MIND diet, okay? Dutch diet, it was designed to decrease the blood pressure and to decrease the cholesterol. So basically, it's a combination of these 2 diets. Now, what they recommend, that's the important part here. What they recommend. This is the things, I'm going to talk about the 10 things, 10 type of food that you need to eat. So when I say daily, it's daily. When I say most of the day, would be at least 5 days. So the first one is green stuff. Everything green. Every day. All these things that you see here, green, okay? Leafy vegetable. And I will be honest with you, I don't like to eat these things, okay? It doesn't have taste. I don't like it. But the only way I can eat this is with a dressing. But this is my sister told me to use this one, to try it. It's good, but it has a lot of artificial flavors, preservative. So it's better to make this at home, homemade, organic. So this is the recipe. Try that. I'm telling you, try that. Pretty good. Okay, you can do this at home. Just get to the presentation later. Don't waste your time writing now. Just get this presentation and try to make this at home. Now, the other thing is the other non-leafy vegetable, peppers, you name it. There are many. And when I say, remember, at least 5 times per week, I mean most days, right? Then berries, at least 2 days per week, at least. Varies. Nuts most of the day. Olive oil to cook or to integrate in the dressing. Okay? In the dressing most days. Now, the other thing is, number 6, is the whole grains. So you have all the whole grains here. You see? Even popcorns. Popcorn is good. Okay? So, but I'm not talking about the popcorn that you get in the movies that it has extra bottle and like 1,000 calories. Tastes good, by the way, but no, I'm talking about organic, the good one. So, but you have many options, but you have to eat this every day, at least three serving per day. Okay, fish once a week. Then you have beans. So from where I came from, we eat a lot of beans. So we eat beans and beans and beans every day. Rice and beans. This is me. Chicken and turkey, at least 2 days per week. Nothing fried, okay? Try to avoid fried stuff. Try that. If you are going to fry, then use olive oil. Yeah. And then the wine. So I put a question mark here because, oh, by the way, this is good. Yeah. The question mark, this is if you are hungry, you get that, okay? It's 100 calories. Oh, no. I think if you turn around, it's 100. But it's less than 100. No more than 100 calories. Okay, this is pretty good. So, wine. So wine, they recommend wine. In patients with Parkinson, you have to be careful. If you don't have any issues walking or with balance, and your symptoms are mild, it's okay. It's fine. But if you are already having issues and you drink wine, it might make things worse because your brain is not able to compensate and you will fall, okay? And you don't need to be drunk for that. And remember, the wine is not just 5% of alcohol. It can go even to 20%, the good ones. But the average is 14%. A beer is 5%. Don't ask me why I know that. Okay, things to avoid. So you know I'm going to say this. So limit. Okay. The idea here is to limit, okay? Limit. Now you hear better. So, butter, cheese, red meat, dry food, and sweet. So the first one, you can eat this once a day, but no more than a tablespoon, okay? The other ones, once a week. Try to limit this. And the key here is, the good about this diet is that they don't eat it. No. You can eat it, but maybe Sunday, maybe Saturday, and that's it. And the other thing is that they also discourage fruits except the berries, milk, and potatoes. Okay, I'm talking about the MIND diet. Different from the Mediterranean diet that they tell you to eat all the fruit that you want. Okay? You need to know what type of fruit has more calories than others. For example, banana, it has one banana is like 1,000 calories. That might be a lot. When I was a kid, I used to eat like 10 bananas at once, but not now. So this is the thing. Now, what to eat to help specific symptoms in Parkinson's disease? Let's talk about constipation. So Dr. B was talking about constipation, and constipation is very common in Parkinson, okay? And even the medication that we use might make the constipation worse. So this is very, very common in Parkinson, and sometimes years before your motor symptoms onset. So things to do. Remember, you need to be hydrated, okay? You need to be hydrated. At least this is relative. It's not like you have to 1.5 liter. If you ask me, what is 1.5 liter? So it's like 3 bottles of water. This is 1.5 liter. Okay, 4 will be 2 liters. But every patient is different. It depends how much exercises do you do. If you are sick, if you have the flu, it depends. If you have diarrhea that day, you need to drink more water. Fiber. Try to get 30 to 40 grams per day of fiber. If you take 1.5 of brand cereal, 100%, by the way, the taste of this cereal is so bad. But this is what it is. Very bad. You get there. You see? You get over 30. So if you eat this thing, good luck with that. But you get there. But you see, you can. Raspberry. I love this raspberry. Raspberry. And orange. Prunes. Lentils. I don't like lentils. Okay. Now, what about probiotics? So, yes, few studies show benefits on constipation in patients with Parkinson. As a matter of fact, the Movement Disorder Society, this is an evidence-based medicine review published in 2019, recommend that to treat constipation in the setting of Parkinson's disease. Okay? The main side effect that you might have is abdominal bloating in some patients, but the majority of people tolerate this pretty well. And what type of food? So, probiotics. So, probiotics is actually bacteria, the good bacteria, to keep the normal microflora. Okay? So, if you see here, I don't eat any of these things. I cannot. You cannot make me eat these things. The only thing is this. Yes, yogurt. Okay, I just ate one. Now, yes, I like this. All of them. All of them. I'm okay with this. But this is the prebiotics. So these are real food to help the good bacteria to survive. It's like feeding the good bacteria. So these are things that you can try. If you like, this is fermented food. Okay, now, low blood pressure. So this is very common that patients with Parkinson, they stand up and they feel dizzy, lightheadedness. And that might be a cause of you falling down. Because we always blame the balance, but could be also the blood pressure is dropping. So, things to do. Besides checking your medications list that your doctor need to check or what medication you are taking that might be exacerbating those symptoms, is after doing that, is you make sure that you are drinking enough water. Enough water. The idea is to increase the intravascular volume. So, again, around 2 liters of water, okay? Which means 4 of this per day. And usually, cool water, try to cool water, when you wake up and with each meal and every time that you do exercises. Now, any food or supplement interaction with Parkinson medication. Few points here I want to clarify. Only levodopa will have these issues. The other medication, unlikely. Okay? Levodopa is the only one that might have these issues. I'm not a fan to tell patients, especially during the beginning, to separate, because I prefer you to tolerate the medication first. It's the first impression. My mom used to tell me that first impression is important. So, because I'm introducing this new medication on you, I want you to tolerate. I don't care about the interaction now. Then we talk about that later, if there is any. Because there is no way I can predict which patient will have this problem or not. Yes, it tends to be more common in patients early onset, young onset, and patients with family history, strong family history, tend to be more common, this issue. But otherwise, no, and sometimes it's not possible. It's not possible. You guys are taking medication every 3 hours, so how can you do that? No, it's possible. So sometimes what we do is just, if this is a problem, you take your proteins at the end of the day, but don't stop, don't quit eating proteins. Protein is so important, okay? So be careful with that. Now, the current recommendation, and she already mentioned that, is the typical recommendation is you take the pill, right? And you wait 30 minutes, and you eat your huge, big steak, okay? Or you wait 2 hours, around 2 hours, 1 hour, 2 hours, more or less. Every patient is different. You need to test yourself. There's no way I can predict which patient will get affected with this. And the other thing is the iron. If you take your pill with iron supplementation, it might bind with the carbidopa and levodopa, both. So it might have a problem with absorption. So this is one of the things I will recommend to separate if you can, please. Try to separate. Now, what is the evidence for supplements in PD? Okay. I would tell you that if you follow the MIND diet or the Mediterranean diet, you might not need supplements unless you have another medical condition. If your body is fighting against some cells that produce or help you to absorb vitamin B12, then you need supplements, right? But otherwise, technically, you don't need supplements if you eat well. But there are some exceptions to the rule. So, I'm not going to ask you how many of you take supplement, because probably more than 50% of you are taking something extra supplement, because this is very common. Actually, in the United States, more than 50%, 52% of the patient take supplements, okay? And 31% of them multivitamins. This is very, very common. Nothing bad about that. And actually, if you see this is we call that pastillas McCoy. I don't know, you heard about that, pastillas McCoy? So this is what my mom used to give me when I was a kid. Okay, I'm still alive. So you eat this, eat this. No, I don't want, eat this. Okay, every day she used to give me that thing. Okay, so, and this is the multivitamins with fish oil, omega-3, so I guess, well, helping me, I don't know. But, yeah. Now, in US, in patients with Parkinson, complementary treatment in patients with Parkinson, 40% of them, okay? Vitamins, you see that? 58%. That's in patients with Parkinson. Patients with Parkinson take vitamins. That's okay. This is very common. Very common. Now, let's talk about supplements. This one on the left, we have evidence that they do not improve symptoms in Parkinson's disease. They do not improve symptoms. There's enough evidence. Actually, coenzyme Q10 in phase 2 trial show some potential benefits, but when they did the trial, phase 3 trial, with over 600 patients and more time with higher doses and low doses, didn't find anything, any benefit at all. So if you are using this to improve your motor symptoms and it's helping you, good for you because it's safe, but there is no evidence for that. The same applies for creatinine and vitamin E. So vitamin E actually might increase the mortality if you take too much. Excessive vitamin E might increase the mortality. And this is based on the at least in the cardiology literature. High doses of vitamin E might cause bleeding as well. In the green corner here, I don't know. I cannot recommend, but also I cannot tell you, don't use it. Because I don't know. Probably nobody knows. We don't have good evidence. So it might not work, okay? And that's the problem that we have. Now, that's the Macuna. Macuna and, do you guys know what is Macuna? No, okay, we'll talk about that soon. So, by the way, if there is something that I believe is American Academy of Neurology and the Movement Disorder Society. So this is a evidence-based review published in 2018 that they did not find any benefit from coenzyme Q10 and creatinine. So no useful, okay? And this is the Movement Disorder Society, 2018. And there is no more data after that. Randomized controlled trial, which is the trial that we are looking, right? So then, what about natural Macuna pruriens? What is that? To understand the present, we need to learn a little bit about the history. Do you know that levodopa was isolated from fava beans, a bean, a long time ago, 1913, many years ago? But before that, before the era of Parkinson, James Parkinson, back in 1817, when he described those 6 patients, in the India literature, there is a description of a disease that we call Campavata. And we think that this is what we call now Parkinson, or what we think is Parkinson, because those patients received Macuna because that's the only treatment at that time, and they, with some improvement. Macuna is the plant with higher amount of levodopa, more than the fava beans. Fava beans is less than 1%, 0.9 to be exact. So this one can go even to 10%. So this is real stuff. Now, if you go to, always when you want to check something, be careful with Google, Dr. Google, okay? Be careful with that. You go to PubMed, and you put randomized controlled trial, and you will find only 4 randomized controlled trials on this, okay? 2 of them, single dose of Macuna, when compared with Sinemet, the medication that you take, pretty good. Actually, very good compared in terms of motor symptoms, improve, with levodopa, non-inferiority, and even better side effect profile. But we cannot get conclusions with only 1 dose. We need to see what happened in the chronic use. So we have a study. Oh, okay. So this study, 16 weeks, all those patients that were able to tolerate the Macuna, they did pretty well, the same as the synthetic levodopa, the same. But 50% of them could not tolerate the Macuna. Either they stopped the Macuna, either because of side effects, GI side effects, or because the motor symptoms, for whatever reason, got worse. So they switch, right? Because it's a crossover, you see? In other words, we don't have good evidence. But it might work. The only thing we need to find a way. But people don't care about doing study with this. I don't know why. But this is what it is. Then, to make things more complex, if you think that you are getting whatever they say in the label, the amount of levodopa, think again, because that's not true. This study, okay, they evaluate 6 commercial Macuna pruriens, and they found significant, you see the range here, from 6% to 141%. So in other words, you know how much you are getting. This is not regulated. It's different from regulated medication that you know what you're getting, what you are supposed. Okay? So that's a big issue with us. That's a big issue with Macuna. But it might work, actually work. Now, whether you ask me, will you take Macuna? I will tell you no. If I live in US, no. But I understand if you live in a country with limited resources and you don't have anything else, yes, of course. But there is no reason for me to take a risk taking this if I have Cinemed or Ritari. Okay? That's my opinion. They might have a different opinion, but that's my opinion. Now, and we are finishing soon. Cannabis for Parkinson. So this is a very long topic, very long topic. And I don't get this question about marijuana in Tennessee, but in the state of Illinois, yes, a lot. Here, not too much. I don't know if because people don't want to ask or because this is a very common thing, very common question. And if you go to another state to work, you see that this is a common question. People want to know what's going on with this, what the data is showing. So, let me give some a little bit forward here. Aha. So, enough to say, and if you guys are interested in this topic, next year we can talk more about this, the whole 40 minutes, just medical marijuana. Now I will just summarize in 2 slides, okay? Now, enough to say that the data is mixed, two conflicting data. In other words, there is no significant evidence in the literature to support the use of marijuana, of cannabis in patients with Parkinson's disease. Yes, there is some weak evidence, mostly observational studies, right? People telling you how they feel, that improve some non-motor symptoms, specifically anxiety, pain, and sleep quality. And something very subjective, which is the quality of life. So is this medication improve your quality of life? I say, yes, okay, yes. Okay? So it's very, very subjective. And not only that, the main concern is interaction, because cannabis, as you see here, is a potent inhibitor. So which means that decrease the metabolism of many of the medication that you are taking. So you have to be careful, because there are many things that we don't understand well, how the CBD and TSH work well, and you might have an interaction with one of your medications, okay? Now, things get more complex because there are many types of cannabis. Okay, I'm not going to talk about details about that. And the other thing is, it's not just the brain, also affect your heart. Okay, and there is a lot of evidence, the effect of cannabis in your heart. That's another topic. Now, common vitamins deficiency in PD. I typically don't check all these vitamins, except, and I should. I think I should. I think we should start doing this because it's very common to find these type of vitamins low in patients with Parkinson for whatever reason, either because problem with the absorption or levodopa is affecting the absorption. How many minutes do we have? Done? Okay, yeah. So yeah, this is the last one. So, if you have signs of neuropathy, when I say neuropathy, like you have numbness or tingling sensation, you need to check for vitamin C and vitamin B12 because maybe you have low levels. And, you know, and if you have other things that predispose you, like being in duopa, getting duopa, that actually causes vitamin deficiency too. So, in other words, I prefer you to get this test at least once a year. Okay? This is what I do. Now, summary. So, avoid all or nothing approach. That doesn't work. That doesn't work. You need to have some freedom. Try mind diet. And if you don't like the mind diet, just Mediterranean diet. It's almost the same. Okay? Be consistent with your exercises routine. Maybe check vitamin B12, B6, and folic, and D annually. spend more time on healthy, fresh food and not on supplements. And learning how to cook by yourself is a good skill. Learn how to cook. I like this book, by the way. This is a very, very nice book to start. Very, very good. And I cannot emphasize more that take care of your body. This is the only place you have to live. Thank you so much.
Thank you, Dr. Zayas. That was a great talk. We're at lunch. I have a couple housekeeping things real quickly. Feel free to use the restroom if you need to. Lunch will be brought to the tables. There's obviously already water on the tables. If you want beverages, they're around the sides of the room. I was informed that if you have diet considerations, there is a diet card on your table. Please raise the diet card when the servers are coming around so they know if you have a particular diet concern. We are also going to have our singing group come up for the first part of lunch. I'm very excited about this. They have been meeting every Friday, and I know that they are very excited to perform for you guys. Cecilia is leading them. I did want to introduce her a little bit. She has been great for our center, so we've been very happy to have her as part of our team as well. Just a little bit about her background. She's a board-certified music therapist. She did her master's at the University of Tennessee and then went on, I apologize. She did her BA in music at the University of Tennessee and then got her master's at the University of Kentucky. I didn't know this about her, but besides Parkinson's disease, she has been involved with a variety of different groups. And I'm just going to read off some of these because it's fairly impressive. She was involved in the public school setting in Kentucky, and she's also treating now adults with dementia, adults receiving treatment for Parkinson's, of course, and I think also people that are dealing with substance abuse. So she is treating a wide array of different people at this point. So again, once again, she's been a wonderful part of our team, and so we're very excited to introduce her and her singing group.
Good? Check. Hello. Hi, everybody.
Hello.
My name's Cecilia, and I appreciate that nice introduction there. I'm so proud of this group here. This is our therapeutic singing group. We're part of the Cole Center. We meet every Friday at 10 a.m. at Faith Lutheran, and Laura Clabo has a support group for care partners that meets some of those days. I just want to real quick say that music and singing are some of the greatest ways, in addition to all of those other things like diet and exercise that were mentioned, to support your overall health and well-being, regardless of whether or not you have Parkinson's disease. But specifically, if you have Parkinson's, it's great for strengthening all of the muscles that are used for swallowing, for speech, and it's a great way to come together and to boost your mood, to experience a sense of community. So that's part of why we do this group, and I have a great time with these folks, so I'm really proud of them. And we're excited to present some songs for you today. You guys good? What? Oh, yeah. You keep saying you've got something for me, something you call love, but confess you've been messing where you shouldn't be messing, and now someone else is getting all your best. These boots are made for walking, and that's just what they'll do. And one of these days, these boots are gonna walk all over you. keep lying when you ought to be truthin'. And you keep losing when you ought to not bet. You keep saying when you ought to be a-changin'. Now what's right is right, but you ain't been right yet. These boots are made for walking, and that's just what they'll do. And one of these days, these boots are gonna walk all over you. You keep playing when you shouldn't be playing. And you keep thinking that you'll never get burned. Ha! I just found me a brand new box of matches. And what he knows, you ain't had time to learn. These boots are made for walking, and that's just what they'll do. And one of these days, these boots are gonna walk all over you.
Are you ready, Boots? Keep walking.
Bum, bum, ba-da-da-dum. Bum, bum, ba-da-da-da. Everybody? Bum, bum, ba-da-da-dum. Bum, bum, ba-da-da-dum. These boots are made for walking, and that's just what they'll do. And one of these days, these boots are gonna walk all over you. Right, and thanks to Shirley for the glockenspiel solo. All right. Almost heaven, West Virginia, Blue Ridge Mountains, Shenandoah River. Life is old there, older than the trees, younger than the mountains, blowing like a breeze. Country roads take me home to the place I belong. West Virginia, Mountain Mama, take me home. Country roads, all my memories gather round her. Miner's lady, stranger to blue water, dark and dusty, painted on the sky. Misty taste of moonshine, teardrops in my eye. Country roads, take me home to the place I belong. West Virginia, Mountain Mama, take me home. Country roads, I hear her voice in the morning hours. She calls me. The radio reminds me of my home far away. And driving down the road, I get a feeling that I should have been home yesterday. Yesterday, country roads, take me home to the place I belong. West Virginia, Mountain Mama, take me home. Country roads, country roads, take me home to the place I belong. West Virginia, Mountain Mama, take me home. Country roads. in a lullaby. Somewhere over the rainbow, skies are blue, and the dreams that you dare to dream really do come true. Someday I'll wish upon a star and wake up where the clouds are far behind me, where troubles melt like lemon drops away above the chimney tops. That's where you'll find me, somewhere over the rainbow. Bluebirds fly, birds fly over the rainbow. Why then, oh, why can't I? If happy little bluebirds fly beyond the rainbow, why, oh, why can't I? Great. Thank you all so much. For these last two songs, we would like to invite you all to sing along. I know you're eating lunch, so don't spit on your neighbor, but we'd like for these last two to be sing-alongs. This next one is called Sweet Caroline. And if you've ever done karaoke, you've probably heard this song. So you'll know the special parts that we need help on. All right, everyone. One, two, three. Where it began, I can't begin to know it, but then I know it's growing strong. Was in the spring, then spring became summer. Who'd have believed you'd come along? Hands, touching hands, reaching out, touching me, touching you. Here we go. Sweet Caroline, ba-ba-ba. Good times never seem so good, so good, so good, so good. I'd be inclined, ba-ba-ba, to believe they never would, but now I'm. Look at the night, and it don't seem so lonely. We fill it up with only two. And when I hurt, hurting runs off my shoulder. How can I hurt when holding you? Warm, touching warm, reaching out, touching me, touching you. Here we go. Sweet Caroline, bum, bum, bum. Good times never seem so good.
So good, so good, so good.
I'd be inclined, bum, 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 to believe they never would. Oh, no, no. Here we go. Sweet Caroline, bum, bum, bum. Good times never seem so good, so good, so good, so good. Sweet Caroline, bum, bum, bum. I believe they never could. Caroline. Bum, bum, bum. Good times never seem so good. Thank you for your help singing that. We have one more for you. One more, and we've got some special shaker pom-poms. I just want to say how proud I am of this group and how grateful I am to Paige and Laura and everyone, Holly, everyone who's made this group possible. I have such a great time with these amazing people every week. I have the best job in the world, getting to hang out and make music with so many beautiful people. And if you're interested in the group, please check out the Cole Center website. This is a completely free group, completely free to the community. You can drop in, check out, see if it's something that you're interested in. We invite people with Parkinson's and their care partners. So we have a really good time. I hope you come and check it out, and hope we get to meet some new people soon. Okay, ready? Only if you want to. Wish that I was on old Rocky Top down in the Tennessee hills. Ain't no smoggy smoke on Rocky Top, ain't no telephone bills. Once I had a girl on Rocky Top, half bear, the other half cat. Wild as a mink, but sweet as soda pop, I still dream about that. Rocky Top, you'll always be home, sweet home to me. Good old Rocky Top, woo! Rocky Top, Tennessee. Rocky Top, Tennessee. Once two strangers climbed old Rocky Top, looking for a moonshine still. Strangers ain't come down from Rocky Top, reckon they never will. Corn don't grow at all on Rocky Top, dirt's too rocky by far. That's why all the folks on Rocky Top get their corn from a jar. Rocky Top, you'll always be home, sweet home to me. Good old Rocky Top, woo! Rocky Top, Tennessee. Rocky Top, Tennessee. I've had years of cramped up city life, trapped like duck in a pen. All I know is it's a pity life can't be simple again. Here we go. Rocky Top, you'll always be home, sweet home to me. Good old Rocky Top, woo! Rocky Top, Tennessee. Rocky Top, Tennessee. Rocky Top, Tennessee. Nice job, nice job. Oh my gosh, so fun.
We're doing drop the mic.
Hey! All right, here we go. Pretty serious. Sorry, I got to be serious on occasion, otherwise nobody listens to me. I also have to be amplified because nobody listens to me. Okay, so doctors are great and all. Doctors, super smart, super great people. However, your best advocate should you ever be in an emergency or hospital situation, especially with Parkinson's, is yourself. So the Parkinson's Foundation has realized this and has provided the Aware and Care Kit. But let me give you an idea of why they have done this. So people with Parkinson's are 44% more likely to be hospitalized than people without Parkinson's. So 44% more likely, almost half. When people with Parkinson's are hospitalized, they are likely to spend between 2 and 14 days longer in the hospital. Hospitals are great and everything, but they're horrible. Everybody there is either sick or injured. I don't know why. So even after that, even after the hospital, people with Parkinson's are less likely to go directly home. They will be directed to a rehab unit or a care unit of some sort. So that is why I'm doing this talk right now. Okay, here we go. Little statistics, and I've got some visual cues here. So 12 people with Parkinson's. All right, here we go. 12 people with Parkinson's standing right here. All right? Capture that. Of those 12 people with Parkinson's, 4 of them will be hospitalized in the next year. So this isn't like your whole life. This is this year. Of 12 people, 4 of them are going to be hospitalized. Of those 4, 3 people with Parkinson's are not going to get the right medications or at the right time. I think we all have a good appreciation of how important having your Sinemet on time and having the right Sinemet on time is. So even in a hospital, this becomes an issue. Of those 3, 2 of them will have complications for other reasons other than the whole reason they came to the hospital. So just because of a mismanagement of care, a misunderstanding of Parkinson's, we have 2 people out of 12 will have complications beyond the whole reason that they came to the hospital. Thank you. Beyond the reason that they originally came to the hospital. And again, that's 1 in 6. So you're looking at a group here where some people are going to have some kind of complications. The best advocate you have in that situation is yourself and your caregiver. And that is exactly why, as I said, the Parkinson's Foundation has developed the Aware and Care Kit. Now, there's a bunch of stuff in here. I could go through it each piece by piece. But there are some things you're going to have right on the spot. There's a magnet you can put up right by your bed or right by your station that says, hey, I got Parkinson's. I got to have right medications at the right time every time. You have a bracelet. You've got pamphlets you can give out to anybody who walks into the room. Just peel them off and keep them coming. Anybody who's in charge of taking care of you, keep them coming. You have medication lists. You can put every medication, name, dose, brand name, whatever it is. Make sure that they know and make sure it's current. So that's a lot to take in. You're put in a really tough circumstance because you have medical professionals who may not understand why you're there or may not understand Parkinson's, yet you're having to tell them about yourself and about your own medications. The hospital action plan is also included in this kit. It's going to give you an idea of how to deal with these situations. When they say, oh, honey, we'll get your medicines between 10 and 12. And you know you're supposed to have them at 8 and noon, on the nose, on the spot, right stuff every time. This can help you get prepared. This is very important for the 1 in 6 of you who may develop complications while you're in the hospital. Big deal. So, Parkinson's Foundation has a table outside. Blake will have a table outside with a whole bunch of these kits available for nothing. Don't cost nothing. They are completely free. That is what the Parkinson's Foundation does. So, but it is totally useless if you don't fill it out. If you show up and go, hey, I got Parkinson's, here you go, and it's blank, they're going to be like, honey, you're going to get your medication between 10 and noon, and it's not going to do you any good. So that has to be filled out, that has to be accurate, and it has to be current for it to do anything for you. So we got enough going on with Parkinson's. Let's make sure that it doesn't get worse should you come into some sort of crisis mode and have to go to the hospital. So again, Blake will be out at the Parkinson's Foundation table. He will have wear and care kits. You are free to pick them up. He only has a limited amount, so let's not stampede. All right, thank you all very much. Let's rock and roll. Woo!
Nobody ever knows, nobody ever sees. I left my soul back then, no, I'm too weak. Most nights I pray for you to come home, praying to the Lord, praying for my soul now. Please don't go. Most nights I hardly sleep when I'm alone. Now please don't go. I think of you whenever I'm alone. So please don't go. Cause I don't ever wanna know, don't ever wanna see things change. Cause when I'm living on my own, I wanna take it back and start again. Most nights I pray for you to come home. I'm praying to the Lord.
Let's resume our conference. So every year we have a special speaker. Last year, if you guys remember, we have Jimmy Choi from Illinois, and we also had Dr. Akbar. Today we are pleased to welcome our special speaker, Dr. Alberto Spey. It will take more than 30 minutes to talk about his resume and background, but I will summarize just in 90 seconds. Dr. Spey is a professor and endowed chair of the James and Joan Gardner Center for Parkinson's Disease at the University of Cincinnati. He's also the president of the Pan American section of the International Parkinson's Disease and Movement Disorder. He's a neurologist, fellowship trained in movement disorder. He completed his neurology residency at the University of Indiana and a movement disorder fellowship at the University of Toronto 20 years ago. He has published more than 300 research papers, articles, and 8 books. One of them read by almost every neurologist in the country, which is the Common Movement Disorder Pitfalls. Excellent book. I would recommend this book to any resident. Very easy to read and very good. Today, he will talk about Parkinson is not a disease, but many. Dr. Spey is truly a master in his field, and you are about to witness it firsthand. So, without any further ado, let's welcome Dr. Alberto Spey to the stage. Alberto.
Thank you, Luis. Thank you very much. Hello, everyone. Thank you very much for having me. Thank you, Luis. Thank you, Chris, the committee of organizers, to have me here. It is, to me, always an honor to be with my fellow Parkinson's tribe. I bring greetings to you from Cincinnati, where I have a clinic for people with Parkinson's disease that we're very proud of, but I can say that you should be proud of what you have here. The very fact that you are gathered in the manner that you are today. I wish I could take a picture of you right from this angle. It's quite remarkable. So congratulations to you all for being here. That is a success. You'll find that you're going to be the most important advocates for the future. Because a key message from this session is we're very comfortable doing more of the same. And we have to change. And that change will be driven by people like you saying, why do we keep on doing the same thing? So these are my disclosures. The only one that's relevant is the one to the bottom. Relates to a particular patent that we filed with my investigators and a company that was created as a result of that to create a protein replacement strategy for patients with Parkinson's and other neurodegenerative diseases. Is now currently undergoing a lot of research at a basic science level. But this is probably not going to be particularly relevant to what we're going to talk, although you'll see that there is a connection. We talked about Parkinson's as if it were one puzzle, and the reason we do it that way is because, in fact, in many of the publications, that's how we refer to it. This figure that you see here is, in fact, one that comes from a specific artificial intelligence type program that allows to capture what's in the literature. It says, based on everything that was reported, now this is now about 9 years old, but it's still is pretty current in terms of the understanding. Here's how we can think of Parkinson's. A famous neurologist in 2017, 200 years after the first ever description of Parkinson's by James Parkinson himself, the shaking palsy, was asked, what are we in Parkinson's research? And he said, do you know that when we start putting together a puzzle, you know how we start from the corners and work our way back in? We have the corners covered. I don't know what that means. When we think of Parkinson's as one puzzle, the problem with that idea is that you have to start thinking, where is the puzzle fitting in? How do the pieces connect? And just as important, how many other pieces? We have come to a point to appreciate that, in fact, even the pieces that we have there are not quite fitting together in the manner we would want to, right? So the way perhaps to start thinking a little different, if in fact there isn't a puzzle, but as many puzzles as people living with Parkinson's, is to recognize that maybe this idea of a puzzle as an isolated thing that would somehow encompass everyone that is living with Parkinson's, that perhaps this could be viewed as a set of different puzzles, as I mentioned, perhaps as many as people living with it. Maybe each of you is a puzzle. And the solution for each of the individual puzzles might be applicable to you and not to one else, no one else. So perhaps we need to just break off from this and recognize that there are different ways into which that thing we call Parkinson's can come to be. And the reason we think of that way is because in every other field of medicine, if that was our mindset, we would say, you have this thing called Parkinson's disease. If we're honest, we don't know what that means to you. We know a lot about Parkinson's, the puzzle, Parkinson's, the construct, Parkinson's, the idea. But we don't know exactly how any of it applies to you. Why? Because other fields of medicine say, we need to investigate you. We need to do a variety of different tests to be able to understand what is it about you that makes you have this thing that we're recognizing, for lack of a better term, as Parkinson's. And that's because in different subtypes of Parkinson's that can be identified biologically, you would expect that there would be a biological therapy for it. So that puzzle is best separated out into different types of biological molecular subtypes. That's actually what every other field of medicine has done with their conditions. That's what breast cancer, when people say breast cancer, all of us know it's not one disease. The name hasn't changed. But saying breast cancer doesn't mean, oh, I know what you have. No. There are many kinds of breast cancer. 75% of all breast cancers fall into 20 different biological molecular classes that are treated very differently. In Parkinson's, though, we looked at every discovery that has been made as a piece in the puzzle. And that essentially converges. We say it must be the same puzzle, must be the single thing, because at the end, what we get is what you've heard. Dopamine deficiency that we can identify via a DAT scan, and this thing called Lewy bodies that require for us still very much to definitively prove with your brains after you've died. Now, there are tests that we can now do in skin biopsies that can do that, but essentially we're saying this must be the same disease because there are two things that happen. You get dopamine deficiency, which is an eloquent type of thing. Many of the symptoms of Parkinson's are in fact related to that deficiency of dopamine. And you get these things at the end that we can recognize as Lewy bodies. Now, that is a concept that we refer to as a convergence and reductionism. The whole is nothing but the sum of its parts. That's reductionism. We're lumpers. Now, I just mentioned that Lewy bodies, we think of them as the beginning. How we came to think about it is because when we had only the microscope at our disposal as the technology to determine how to make sense of the world, we looked at brain slices of individuals who had died of what today we refer to as Parkinson's, and saw these things called Lewy bodies. That's shown right there. And it is a forensic approach. A forensic approach means you come to a crime scene and make sense of the crime. How many of you have come to a crime scene or seen a crime scene in movies, and anyone among the characters of the movie looks at the crime scene and says, ha, these corpses were in fact the ones that committed their crime? No one. Right? That is in no plot, in no crime scene ever created. That's our crime scene logic. That's our original sin. We came to the crime scene of an autopsy, looked at the corpses, gave them names, Lewy bodies, and decided that they were the perpetrators of the crime. Never paused for 1 second to think that they may have been the victims, or, for that matter, the last standing soldiers. Well, so these things come from somewhere, and Lewy bodies today were normal proteins yesterday. We have names for them: it's monomeric synuclein, and synuclein is actually the key constituent of the Lewy bodies. Synuclein was preserved since before we came to Earth. There is evidence of prehistoric animals that had synuclein in them. Not only that, alpha-synuclein, which is the protein that mostly becomes Lewy bodies, has been made redundant by evolutionary forces with beta-synuclein and gamma-synuclein. And then, get this, synuclein is in every cell of our bodies. It's everywhere. It's in every species, it's in every cell of our bodies, even in the red blood cells. That's why when people quantify synuclein in spinal fluid, we need to make sure that there are no red blood cells because they contain synuclein. Synuclein everywhere. Do we think that evolutionary forces somehow were at play to preserve synuclein for us so that they would turn into Lewy bodies and act as our built-in toxins? Yes, that's the answer we think it is. Yes. And it is, I hope you can begin to tease out a beautiful, compelling, logic idea that's false, nevertheless. So we accrue something that's no longer functional and lose something that probably is very important because it's in every cell of our bodies, preserved since before we came to Earth. And it's interesting to have to say this in 2023, but proteins can only function when they're normal. I'm going to say it again. Proteins can only function when they are normal. Sounds like I shouldn't say it twice, but in fact, we've done this concept. And essentially, if you think about this in terms of things going up and going down, I was having this discussion with Dr. Sayas earlier, and essentially, if proteins turn into Lewy bodies, the more of them turning into Lewy bodies, the less of them we have. But if I tell you the story with only one of my hands, with just the bottom part, I'm giving you a one-sided story. That would be a one-sided story. You would not be told that the more of this I have, the less of this I get. And if this is the only protein fraction that can give us the functions our brains need, we are deliberately overlooking that which we are losing. And Parkinson's is conceived as a neurodegenerative disease. Degeneration implies loss. What are we losing? Well, if I tell you what we're gaining because I'm not telling you what we're losing, the whole story about Parkinson's becomes, we have too much of this stuff. And if the story of Parkinson's is we have too much of this stuff, what's the solution? Getting rid of it. That's the solution for every neurodegenerative disease, and we have nothing to show for that effort. Over 2 decades of trying. There is a new drug for Alzheimer's called lecanemab that gets rid of this, and we think is good. It has all sorts of harms, actually. Getting rid of the amyloid plaques in the brain, which is the Lewy pathology of Alzheimer's, is very toxic, is very harmful. This is a reactive mechanism. It's a normal reaction. This is a normal reaction to something the brain is fighting against. The one thing that it does is that it increases the levels of the normal protein, but that's hitting the supplementary material of the article in the New England Journal of Medicine that reported the data on the trial. So, every story, when it's presented in one side, it's going to mislead. And the key message to you is to remember the story is not one-sided, it has two sides. So if you look at this brain, as a brain is exposed to, with aging, toxic, biological, infectious exposures, different things as we age. What happens is, look at the brain and pay attention to it, and it's going to change. That change is normal, is a normal reaction of a normal brain, but you might have lost sight that as I ask you to pay attention to the brain, something changed around it. And that's what you see here is actually the loss of the normal proteins, because if proteins turn into clumps, you're losing some of the normal proteins. And that's a process of protein transformation shown here, where a surface, in physics called a nucleation surface, catalyzes the soluble to insoluble, we call the liquid to solid transformation. What happens in the brain is very, very much what you see through a window in winter. I don't know how cold the winters are here, but in a cold winter day, if you have a differential of temperature and you have moisture in the window and you see out, you see these little crystals forming. That's a transformation from liquid to solid, and that's what happens to our brains under a variety of different conditions. What is shown here is just a little ball that actually lowers the nucleation barrier and allows the second law of thermodynamics to proceed in a process of nucleation, which in the case of proteins we call it precipitation. What we end up with is not anything that is toxic. What we end up with is a specific configuration called amyloid that is just a very, very clumped up version of a protein that can no longer function. The certainty, when we get the final stage, is that a protein that would have been functional when liquid, the soluble state, becomes non-functional. That's a certainty. The uncertainty is the minute it turns into this thing, it must be a toxin. And I'll show you that's not the case. So you would think, though, that if we measure synuclein in the spinal fluid of individuals with Parkinson's, we would know that the problem is the loss of synuclein. And yes, it's actually well known. All sorts of proteins are low in the spinal fluid of people with Parkinson's compared to age-matched controls, people that have the same age but don't have Parkinson's. So proteins are low in concentration. We've known that for forever. And so what we did at some point in the past was to just ask a simple question. Let's remove all the clinical features from one of the large cohort studies that we have called the PPMI, the Parkinson's Progression Markers Initiative. Let's remove everything. Tremor, not tremor, dimension of dementia. Let's remove everything and just talk about these two things that are most objective that we are measuring. One is the brain volume, how much of a brain there is, and the other one is how much of the synuclein, the normal protein, there is. And of course, the study wasn't powered for this particularly, but you can look at these two pieces of data and find that they are linearly correlated, that the more of the normal proteins you have, the more brain you have. The less of the normal proteins you have, the less brain you have. That proteins probably are there for a reason, and that we want to keep them under certain levels. Now, this is a study from 2011. There are many, many examples, but I wanted to just show you this mostly because this study has two axes. Here in the x-axis, it says number of Lewy bodies in the nigra. The substantia nigra is the part of the brain that makes it dopamine. And in the y-axis is the number of nigral neurons, how many neurons there are. So what you would expect to see if the idea that pathology, that the Lewy bodies are really the main problem in our Parkinson's patients, is that the more of the Lewy bodies in the nigra we have, the fewer neurons. Because in our story, one-sided story, as I've told you, the more Lewy bodies, the worse you are. In fact, in many studies, this is one of the earliest, and I like to present one of the earliest because it's actually showing us exact opposite, that there is a positive correlation, and that the more Lewy bodies you have, the more neurons you have. And so, in fact, the very first investigator that looked into synuclein, it was in the late 90s. And we didn't have as much of our biases in our story of Parkinson's then. And he had a model. It was the first one that ever talked about synuclein. This was just about the time that things were about to change, but he was still an independent-minded investigator. His name was Bob Burke. He was at Columbia. And he had a very interesting MPTP model, was a model that was already in existence at the time. And he found that cells destined to survive must aggregate synuclein. That synuclein was a normal reaction of a brain under stress, and that only cells destined to die would not aggregate synuclein. And in fact, that data borne out in our human studies. There is not a single human study has ever shown the opposite to what I'm showing you here. It never shown in humans that synuclein is bad or that the Lewy bodies into which they churn are somehow toxic. But that's the story of our lifetimes. This is what's driving every therapeutic effort. And I'm using my fingers to you because I think that you are going to drive the change. Because we neurologists think very highly of ourselves. And we're traditionalists, meaning we like to keep things the way they are and honor those that preceded us. We talked about we're working on the shoulder of giants. So I've shown you this before. You know that normal proteins turn into, in an irreversible process, through aggregation into Lewy bodies. Every single one of our studies in the pipeline that relate to synuclein are to prevent its formation or clearing the Lewy bodies. Every single one. How many of them are there to prop up the normal synuclein that we know we're losing? 0. So this therapeutic pipeline needs a balance. In fact, I would argue we already have all the evidence we know, because trials have already been done, to show that removing synuclein chases a tail. Removing synuclein in an aggregated form is like killing a messenger. The Lewy bodies are there telling you your brain is fighting something, and actually, if we really looked at the data, it's fighting something quite successfully. Lewy bodies are a sign of success. The brain is doing it. It's a messenger, and nothing good happens when you want to kill a messenger. So people would ask, no, you know what? The trouble here is that we haven't put enough investment into Parkinson's. I think if we just put more money into it, we'll get there. And I'm not against investment in research. I'm a researcher in many ways. I think it's important to invest. But investing in bad ideas gets us nowhere. So more money alone is not the solution. This is all the trials in the pipeline for Parkinson's. On top of the circles, this is 2022, 2023, DMT, disease modification. DMT, disease-modifying therapies, means everything on the upper part is to slow progression. Disease modification is the other term for it. Anything on the bottom is ST or symptomatic therapy, is to enhance symptoms. I would argue everything at the bottom we should keep on doing because symptom enhancement is very important. But we think that disease modification, everything on top, is about the same program than developing symptomatic therapies. And it is not, unless we believe that Parkinson's is a single puzzle that applies to everyone. And I hope by now you don't think so. All we have is a graveyard of therapies. So it's not like we're not trying. By the way, this graveyard is just the ones that have reached to phase 3. If I were to put the ones that began in that phase 1, phase 2, and died at phase 1 and phase 2, this would be a really large graveyard. So it's not like we're not trying. It's that we're trying the same approach. People say, no, hold on a second. We're trying new things, new molecules, but not a new approach. We are the only field of medicine that doesn't do clinical trials to test hypotheses. Clinical trials were created because it was the only way to test a hypothesis. The only way. We had nothing else. But we neurologists think that the brain is very complex, which is a very important excuse to justify our failures. But more importantly, we say we do clinical trials to learn. We're learning. We do trials to learn, which essentially means that all of our hypotheses remain protected from the data against them. You never see a trial in neurology starting with the sentence, we conducted this trial to test the hypothesis that this drug would reduce synuclein and that the effect would be positive. No, you just said the trials are, we tested this drug that reduces synuclein. Enough said, must be good. And of course, the trials are invariably negative. And what are the lessons? Because we're learning, we're doing trials to learn. Well, the lessons are, the dose was too high, the dose was too low. The measurements weren't sensitive enough. We just didn't quite pick up the things that we were supposed to be picking up. The design wasn't the best design to do. And our favorite excuse, patients already had symptoms. They already have a disease. We need to do the same trial just before patients have this disease. We call that prodromal Parkinson's. Prodromal Parkinson's means people have some symptoms like loss of sense of smell, constipation, REM sleep behavior disorder, but they don't have anything on a motor level that allows somebody like me at the bedside say, you have Parkinson's. From this point forward, you have disease. Yesterday and earlier, you had a prodrome. Who am I to serve as the arbiter of biology? Why is it that there is a magical point at the bedside where I get to say to someone, here, I've come to recognize that everything I've seen makes me conclude you have Parkinson's. Trust me, I'm an expert. So quaint, but not for this century. I should not be allowed to say that I own the truth, that I, by virtue of my experience, can define what you have at a molecular biological level. So the main problem with the trials is not the molecules aren't good enough or we're acting too late. Imagine our oncology colleagues saying, this trial in cancer failed because people have cancer already. Let's do it when people don't have cancer. Every single drug that has been used in oncology, in cancer treatment, early, has first been demonstrated to be effective late. It's not like any other field of medicine has an example of something that didn't work at the disease state and somehow only worked there is no such examples. I've been in a search for this. The only example of something that we can give early for protection is vaccination, but nothing else really. There is no therapy that has ever been used to prevent some disease that was not first demonstrated to help that disease. So, what to who? So we have lots of whats, lots of medications, right? But we don't have an assay to allow us to connect that medication to those that actually would have the biological suitability to benefit. So how do we do biomarkers? Biomarkers are tests of a disease. We consider them, if we have a biomarker, that's one of the things we need to have in order to be successful. But here's how we do it, or how we've been doing it up till now. So I've already said, trust me, you have Parkinson's because I'm an expert. So that's the gold standard. That's the truth. That's, in statistical terms, the independent variable. That we know it is. Let's find out what is going to validate that which we already know to be the truth because I said so. We then create groups. Here, for instance, Parkinson's, because we say so. Here is controls, right? People that we don't find anything neurological. And then we measure as much as we can of them because we want to find what correlates with one group that doesn't with the other. And in the process, we would refer to them as biomarkers of Parkinson's. Instead, though, since those biomarkers haven't really gotten us nowhere, what we need is a change to understand why we're aging in funny ways, some of which have the name of Parkinson's, some of which have the name of Alzheimer's, some of which have the name of dementia with Lewy bodies, etc. In an agnostic fashion, rather than us saying what you have, how about we pretend we don't know? And then we essentially study a variety of different signals that happen to be meaningful because if we know where the range of abnormalities are, we might be identifying individuals that would be amenable to specific interventions that we can today use to correct that problem. That's the principle of precision medicine. Precision medicine is not saying, trust me, I'm an expert, you have this disease. Precision medicine is saying, trust me, I don't know. I need to study you at a level that allows me to understand you biologically, so that then I'll know what treatment will work for you. Meanwhile, here's levodopa to make you feel better, right? Levodopa is great. It will always be great, but it's never going to be sufficient to enact precision medicine. So what we're doing in Cincinnati is the first of its kind in the world, is this idea. We've been saying no two people are alike, but we've never done research to act as if we mean it. So we are doing it. It's a lot of effort. It's a village. It's just like this village. You guys can start doing this here as well. This is going to be very important. It's the only way out. It would be nice if, with the concepts I grew up under, that Parkinson's is one disease and one day will be cured, it would be nice to believe in that idea. It sounds a great slogan. Certainly the Michael J. Fox Foundation, to which I'm very grateful for the support over the years, has been perpetuating this myth that if you give us money, we'll cure Parkinson's. We're here until Parkinson's isn't, is the slogan. I think it's a great feel-good slogan, but no, it's not the right way, right? Like, hope for the sake of hope is meaningless. We need to have hope based on a reality. So we have this study, it's a CCBP, we have a large set of collaborators, and essentially what we're looking for is biological drivers of individuals with specific forms of Parkinson's, but also for different forms of other conditions. We, in fact, here aren't saying, here's Parkinson's, here's Alzheimer's, here. We have people with different kinds of conditions, and we're trying to explore them as best as we can. You can see that we are looking for the needles in a haystack. This is a fishing expedition, and that term fishing expedition has a bad reputation, but it is the only way to get to the moonshot of identifying who is it that are out there that can have a cure today. I suspect that there are already treatments that would reverse disease in people if we knew who they were. And this is the platform we've created here. So we are biotyping, essentially. We're trying to get to this idea, and it's just a playbook from oncology. This is not revolutionary for oncology at all. That's what they do all the time. They determine the extent to which there are personalized biological signatures that allow an oncologist to say, this is the treatment for you, not these other things that we could have given you. This is where we are. This is screenshot of just essentially all the effort that's like, this takes a village. It's a whole team dedicated to this. And just to simply show you that we're also following individuals longitudinally. There is a biobanking of their tissue. We're not doing spinal fluid, but every other tissue we can collect, we're collecting it. And so that then becomes the grounds on which we would begin to test all of the assays. We've created assays for therapies that already exist, that we know are important. We just don't think that they were junk molecules. Rather, we never knew who they were for. And so what we want to do, too, is that for future clinical trials, and this is something that we propose today in NIH, is to have tiers of selection. And essentially, I want you to think just from your perspective of tier 1. Somebody like me is going to ask you to come for a study, for a trial of a disease-modifying treatment. Somebody's going to say it. Probably you've already been invited, perhaps. I want you to ask the question, why me? Why are you asking me to be part of your study? Remember, this will be for the upper half of the circles, the disease-modifying treatments. Symptomatic therapies, by all means, it is all about lumping. It works okay, but lumping cannot work for disease modification. Splitting is necessary. So the answer to that question by your physician inviting you to a study is, Well, because you have Parkinson's. In fact, you're great because you have early Parkinson's. I hope by now you know that's the wrong answer. No. I want you to tell me, what is it about me, biologically, that makes me a candidate for the therapy you think is going to slow my disease that might not work for others? Here is perhaps one of the most important aspects in which you can make a change, to ask why me. Because the why me is going to say, well, also because I know you have synuclein, and synuclein is bad, right? That could be another. So I just want you to be critical and not simply participate in research just because participation in research is good. No, there are certain kinds of research that we now recognize are not going to lead us anywhere. We don't need to expand the graveyard. Now, I'm going to tell you a story just on one trial, and I think I have just enough time. 5 minutes. One quick thing. So essentially, low urate is being known to be associated with a high risk of Parkinson's. And then low urate people who have Parkinson's predict an accelerated course of Parkinson's. Those that have high levels of uric acid, have slower progression. It only makes sense to say, hey, it sounds like we have something here. Urate is a natural free radical scavenger, an antioxidant. Let's give more of it. And there was a study that we did a while back. It's the only study that pre-selected patients on the basis of a low urate. And that meant including 40% of everyone with Parkinson's. We accomplished that. We increased urate exactly as we wanted to, and nothing came of it. That slice of the pie was 40%. So 60% of individuals with Parkinson's have normal urate, 40% have low urate. We increased that 40% to the levels of the high urate, and nothing happened. We were also chasing the tail. Further splitting clearly is necessary, and that's a lesson here that I think we need to keep in mind. So I hope that I have convinced you that there is really a need for us to start abandoning this idea that proteins are toxic. No, we need proteins. Proteins are very important. Proteinopathy means diseases of the proteins. The proteins are not disease, they are victims. They are victims. Moving from convergence, trying to make sure why is it that all of us are alike, rather than from that to moving to what is it that makes us all different from one another. We say, don't compare yourself to others. Everybody's different. Then we need to go to the next step and act as if we mean it by developing divergent biomarkers that are going to be unique to you but not to others. And finally, ask the question, what is it about any trials that we're going to be doing that has a relationship with your biology? Because if not, you're not doing the matching of the what to the who. So I hope that in the future, instead of having hundreds of patients in any clinical trials, there will be just 10 or 20, because it may well be that the first success in disease modification, in neuroprotection, in reversal of Parkinson's might apply to 1 or 2% of individuals. But success can begin in a small way, and then you expand it. We want to have it all at the beginning. We want to cure Parkinson's, and it cannot be cured because Parkinson's isn't a disease, but many. Thank you. There's no time for questions, is there? What's it? It's 12, 1:10.
5 minutes?
Any questions? 5 minutes of questions. No? Good. Oh, yes, there's a question over here.
I had a patient at one time that played football at UT, and back in the days when they wore the leather helmets and stuff, and he developed Lewy bodies. Oh, thank you. He developed Lewy bodies, and his abilities would decrease from time to time, but then he would go back up, not quite to the level that he was prior to, but he, would go back somewhat instead of it just losing all the capabilities that he had. And so I was wondering if the trauma from the head injuries and stuff, if that could have been part of what caused his Lewy bodies and his...
Yeah, so great question. The question is anybody with traumatic events in the brain potentially at risk for neurodegeneration. Not a single event. It's not believed that a single event could do it. And the term is chronic traumatic encephalopathies. If there is sustained and repeated traumas in the brain, then that can harm the brain. Now, the Lewy bodies are a messenger. It's not that the Lewy bodies cause the dementia. The trauma causes dementia. The Lewy bodies were a reaction to it. And what he lost probably is the proteins from which Lewy bodies came. That reminds me that there is a natural model for chronic traumatic encephalopathy. Does anyone know what is the natural model of chronic traumatic encephalopathy? Who said woodpeckers? No. Woodpeckers, they bang their heads at a force that is about 20 times above that of most of the typical football player injuries. 20 times above it. That's crazy. How do they manage? They have lots of these proteins clumped up. They have a specific protein called tau. Their brains is filled with tau. Tau is a helmet. But in our narratives, like, oh, that's why they're doing what they're doing. They are filled with tau. They're crazy birds, right? No, that's what they do to build it up. There's a study done where people don't sleep only one night. They were checked with a PET before, no amyloid. They were asked to sleep deprive themselves one night, and then the next morning, a PET scan was done. Guess what happened? They have amyloid in the brains. The conclusion of that, this was about 3 years ago, was that sleep deprivation represents a risk for Alzheimer's. Maybe, but that's actually not borne by the data. Yes, sleep deprivation can be part of the symptoms of people with Alzheimer's, but a very different explanation with the same body of data is that sleep deprivation represents an injury that the brain reacts against by building amyloid. It's the same data, different interpretation. So I hope that sort of, in a panoramic way, can answer that question. Yes, you have.
Yes, sir.
Yes.
If Lewy bodies are the messenger, do we know where they're carrying the message from and where it's going to? And has any research been done trying to reverse the effects? Instead of saying Lewy bodies are bad, is there any research being done to say Lewy bodies are good? Now let's find out why.
Yeah, good question. So the short answer is no. Very little has been done in that direction because remember, we're talking about this one side of the story and this is going up, which is, you've heard the term accumulation of Lewy bodies. They don't accumulate. They're just the insoluble, the solid fraction of the normal proteins that no longer are there. So most of the research is done in terms of the other side to understand the function of the normal synuclein. But that's where it ends. So for instance, I went to the synuclein meeting last year, synuclein 2022, that was the meeting in Belgium, and actually it's fascinating to know that the entire first day of the meeting was, what does synuclein do? And a whole bunch of things. Synuclein is involved in everything. And the very next day was, what are the biomarkers of synuclein and how we can get rid of it? So I told them, I said, thank you for inviting me, because of course they knew I was going to probably talk to them about something they didn't want to hear, which to their credit, they invited me in. But I said, I'm going to give you a proposal. The next time that you do a meeting like this, great to have a whole day on function of synuclein, but then you need to follow that with a day of what happens when the functions are all gone, right? So it's a blind spot. There are two major blind spots in our research, that which you identified, and the other one is, well, ultimately, proteins are probably not trying to immolate themselves, to die, to convert themselves into Lewy bodies and cease to exist. What's driving them? So that's the other invisibility of research. And that is because that's the hardest. Everyone has a different reason why that happens. Somebody could be a traumatic brain injury, somebody else could be a virus, somebody else could be a toxic exposure. So, thanks everyone. It's been a pleasure. Thank you.
Fantastic talk. I'm really glad he came. I feel kind of like a dead man walking right now because I am following that and I am going to have a lot of traditional stuff. So I will tell you, I've heard him talk many a time, including in our big international conferences, and I've seen him debate up on stage this whole concept, and he makes a lot of good points, but I am going to put in a little traditional, and I do think hope is important, so. We are going to have a couple people coming up to show us some exercises. We're going to have two of our physical therapists that work with us in clinic. Courtney and Whitney are going to be coming up and showing you some of the exercises that hopefully will help you with your Parkinson's. And then I will give my dead man walking talk.
Good afternoon. Oh, it's very loud. So great to see everybody here today. I'm Whitney. I am at the UT Medical Center facility, and I see folks there. Courtney is at our Hardin Valley Clinic, and we have other PTs at most of our other UT clinics that do big and loud and other Parkinson's groups. So Margaret led us so well this morning with the power moves. We're going to add on to that a little bit today. So I want you to put your thinking caps on if it's not too, it's that after lunch lull. And Dr. Zayas talked about how we love eating, and that's true. But we also love exercising, right? How are you doing with your exercises at home? Everybody doing good? Finding something you like? All right, so let's start out, and you can do it in sitting or you can stand up. We'll start out with some breathing and moving a little bit. So sitting up nice and tall in your chair or standing up nice and tall. We're going to open up our chest and breathe a little bit. So open your arms, stretching behind you. Take a deep breath. Exhale, come all the way down. Good. Now open it up and breathe again. Stretching, open those arms. And breathe it back down. Exhale. Let's inhale as we come up again. Exhale as you come down. Inhale as you come up. Exhale as you come down. Now, if you're standing, great. If you want to stand up with us, go ahead. Make sure you got a little bit of space around you. So we're going to try some of those power moves again. So first we're going to power up. So make sure your base is wide. If you need a chair to hang on to, that's an option as well. So I want you to reach forward and then power up. Open it up. Open your chest. Nice and tall. And reach forward. Power down. And then power up. You guys look great. Let's power down and power up. Take a deep breath. Let's do one more. Power down and power up. Good. Now we're going to rock. We got our feet wide. We're going to come up on the toe and shift to one side. So we're going to reach up, hold it up there. Can you look up at your left hand and keep your balance? Opening everything up and come all the way back down. Good. Inhale, come all the way up. Reach your left hand, open your right hand. All the way up at it. Look at it if you dare. And come all the way back down. Good. Exhale. Reach up. Now this time I want you to flip that hand up and down. Flipping the wrist. And bring it all the way down. You guys look great. Reaching up on the other side, flipping. And coming all the way down. Up on the left again, reaching up. This time let's flick those fingers like you've got water on your fingers. And we're going to flick it off. And come all the way down. Good. And reach up, flick it off. And come all the way down. Good. Now we're going to rotate Arms are really wide. We're going to twist on our left toe as we go to the, well, let's see, on your right toe as you go to the left. So twist and open all the way up big. And twist and open and twist and open, twist and open. One more time on each side. Let's twist and open big, twist and open big. You guys look great. Now step in with your feet. We're going to step out. So our feet are together. Now we're going to take a big step out. Hold a chair if you need it. How's everybody doing balance-wise? You look good. And then step in. Step out. Step in. You guys are awesome. Step out. Don't step on your neighbor's toes. And step in. Careful out there. Step out. Step in. Step out. Step in. Step out. And in. All right, now, am I out of time? I have a little bit more time. So let's try to put this all together a little bit. We're going to put them together. We're going to come forward, and then we're going to rock, and then we're going to twist, and then we're going to step. So let's think through it together. Are you ready? Put your brain to it. We can do this. Reach forward. Power up. Our feet are wide. Now we're going to rock up and down. We're going to rock up and down. Now we're going to twist. Twist and open. Twist and open. Step in, and we're going to step out. Step out and in. Step out and in. All right, give yourself a hand. That was awesome. You guys did great. Thank you. I knew that.
Okay. Hello? Oh, there we go. Okay. So I am very proud to present Dr. Christopher Tolleson. So he is one of our movement disorder specialists. He's also our medical director at the Cole Center at UT. He went to medical school at the Medical College of Georgia, and then he did his neurology residency at the University of North Carolina, Chapel Hill, and then he did his fellowship for movement disorders at Vanderbilt University. As you all can remember, we didn't have much in East Tennessee when it came to movement disorders. And now we have so many resources that we never had before. So I watch Dr. Tolleson, like he sees his patients day in and day out. And in the after hours, he is sending emails, meetings, messaging, and trying to get people to do more for movement disorders, to bring in more resources. He's been instrumental in hiring new movement specialists, DBS program, our Cole series, having social worker, having assistants in the clinic. And now in the hospital, he pushed the hospital and said, we need to be careful what we're giving people when they come into the hospital. We need to make sure we're not giving them the wrong medication to hurt their symptoms, and we need to make sure we give their medications on time. And he never asked for a thank you or asked to be recognized, but today I want to tell him thank you. You've done so much for us. Yeah.
I'm gonna get emotional. Sorry. Thank you. I'm probably a podium guy, and I don't want to fall off, so I don't. All right, so I really do feel like I'm a dead man walking a little bit, so I'm gonna do my very best. So, my title of my talk is "The Future of Parkinson's Care: What's in the Research Pipeline," and I really do want to give you guys hope and encouragement for the future. I'm going to be talking a lot about symptomatic therapies. But also some of the things farther along, like the disease-modifying therapies that Dr. Espay was referring to. These are my disclosures. I really don't have much. I did something recently for AbbVie but nothing has any bearing on my talk. This is an outline of what I want to talk about. The phases of clinical research I really want you guys to pay attention to because I will be referring back to them when I talk about the different therapies that are in the pipeline. I'm going to talk briefly about biomarkers. In the Parkinson's world, we're really talking about biomarkers when we're trying to find things that would help us identify Parkinson's more accurately, earlier, then hopefully follow things over time. And then in terms of therapies, I do want to talk about the symptomatic therapies, which if you heard from Dr. Espe, are therapies that should cover up symptoms or help symptoms. And then disease-modifying therapies is where we ultimately want to get to. These are the therapies that may slow down the disease or stop the disease. And then finally, I want to make some conclusion statements. So if you talk about the phases of clinical research, phase 1 in human research is a safety trial. This is typically smaller numbers on the orders of about 20 to 80. We are looking to see if patients are safe on the medicine, but also what kind of side effects they have. And this is typically a dose-finding study as well. We're looking to find what dosage is helpful for the patients. This is typically on the order of months to a year. And then if this passes through phase 1, it moves to phase 2. And this is the potential to work. So we're looking at larger numbers, we're looking at safety, and we're also looking at perceived benefit from the dose that we discovered in phase 1. This is typically a little bit longer on the order of months to maybe a couple of years. Okay. This is hard. Phase 3 is our big trial. This is the trial that we ultimately take to the FDA to get the drug approved. This is typically larger numbers in the hundreds, and with this trial, it's a comparative trial. We're comparing our study drug either to standard of care or to an inactive drug, which we call placebo. And typically, this is also what we call a blinded trial, which basically means that both the study coordinators and the patients are not aware of whether or not the patient is on the standard of care or the placebo versus on the active drug. This is typically a several-year study. And if it does get get past phase 3 and gets FDA approval, sometimes we'll do a phase 4 study. This is a post-marketing trial. This is typically also a several study, several hundred patients, and basically we're looking to see how patients do on the drug once it's marketed. We track their side effects, we track their benefit, and we track their safety. So some basic statistics from clinical trials. It takes a long time. On average, you're looking at about 10 to 11 years for a drug to get from phase 1 to FDA approval. And also, a lot of drugs, unfortunately, don't get through the process. Less than 10% of drugs that move through these phases get FDA approval. So as I start to talk about the biomarkers and the trials, I did want to have a couple of disclaimer statements. For my presentation, I'm focusing on the medications which have reached human trials. I'm not talking about the many things that are still in animal models. I'm focused on treatments for motor symptoms. So if you hark back to Dr. Barbu's talk, these are your movement problems. These are the things that we're looking for in an exam. This is your tremor, your walking, your stiffness. I'm not talking about all the many other things that you can have problems with. So constipation, bladder issues, thinking issues, sleep, etc. Those trials are out there. But I'm already probably going to run over. So just because of my time constraints, I'm just going to be focusing on those treatments. This is still not a complete list of what's being studied. If you don't see your favorite trial up here, feel free to talk to one of us afterwards, and we'll be happy to talk to you about that specific trial. So I really hope this presentation is one of hope and excitement. The last 2 bullet points on this slide, I think, are that. So I did a similar presentation to this, I think, in 2018, and I cited the Michael J. Fox website. At that time, there were 90 trials listed. We now have 345 trials listed. I also don't remember any trials on Parkinson's mimics, and so I've listed some of the common Parkinson's mimics there below. We commonly will call them Parkinson's plus syndromes as well. We don't have good treatments for those. And you can see that we're starting to research those more as well. So some of you guys may be familiar with some of these terms. Some of you guys maybe have been told that you have these Parkinson's mimics. So we're starting to move forward with medications for these as well, which is exciting. So I've listed here the numbers next to them, but MSA, progressive supranuclear palsy, dementia with Lewy bodies or Lewy body disease, and cortical basal degeneration are all things that we see in the clinic that look like Parkinson's disease. So biomarkers. So again, when we talk about biomarkers in the Parkinson's world, we're talking about things that help us diagnose Parkinson's more accurately, earlier, and then hopefully follow the disease over time. We do not have a good biomarker, but we do have several studies that may help support Parkinson's disease or a Parkinson's-like condition. And I've shown these here. We've talked a little about these over the course of the day. If you look in the bottom left of the slide, you see a picture of a DAT scan. This looks at dopamine uptake or dopamine activity. And if you look at the very far picture, this kind of colored area, that's dopamine activity. And that's what we want. We want to see this nice comma shape. And then in the Parkinson's brain, or the Parkinson's-like brain, I'm using very specific terms, it's much decreased. So it almost looks more pinpoint. We also do skin biopsies where we look for alpha-synuclein. And then finally, this is an illustration of a lumbar puncture. And we can look for abnormal alpha-synuclein in the spinal fluid as well. So there's different ways that we can support Parkinson's disease or a Parkinson's-like condition. This is a very, very important statement, so please hear me. These tests do not diagnose Parkinson's disease. Parkinson's disease is a diagnosis made by a clinical exam and listening to your story by some of the people over here in clinic. We do not have a test to prove Parkinson's disease. The way I try and explain it to people is when we do these tests, they put us in the Parkinson's or Parkinson's-like world. So in some cases, these tests can be very, very helpful because there are some things that are a little iffy and we're not sure they're in the Parkinson's world or not. So you may have heard the term essential tremor. Sometimes it can look Parkinson's-like. Certain medications can cause a Parkinson's-like state. And in this case, these tests can potentially be really helpful, but they need to be done in the right setting. And so talking to your doctors and your neurologists can be really helpful because not everybody needs these tests. But again, one more time, they can be helpful and supportive of Parkinson's or a Parkinson-like condition. They are not diagnostic for Parkinson's disease. All right, so I wanted to talk about one study that came out this year that created a lot of buzz, even at a national media level, and I got a lot of questions about it in clinic. This is a large study looking at the spinal fluid test for alpha-synuclein. This was sponsored by Michael J. Fox, and I know Dr. Barbu already touched on this as well. But just some highlights for me from this study. It was a large study. It was over 1,100 patients. And just some basic groups in this study. There were 545 Parkinson's patients, 163 patients that were what we call healthy controls, or they didn't have Parkinson's or a neurodegenerative condition. And then there were 361 with risk factors that we thought would lead them probably to develop Parkinson's disease in the future, but we did not know that for sure. The clinical risk factors that we were looking for were acting out of dreams and loss of smell. And the genetic risk factors, two of the more common ones are something called LART2 and GBA. And what they found, and I'm going to use accuracy on this slide. Technically, it's something called sensitivity, which means the likelihood that a positive test really does indicate positive disease. But the sensitivity of PD diagnosis was overall about almost 88%. And when patients had loss of smell, it rose pretty spectacularly to 98.6%. Also, a thing that I pulled from this trial was that if you had risk factors for future Parkinson's, again, we don't know you're going to develop it, it was positive about 86% of the time. And then if you had a genetic mutation in your Parkinson's disease, one of those two that I mentioned, LART2 or GBA, it did not have as good an accuracy. I think the sensitivity for the LART2 was about 67%, so it was much less. So things that I've told my patients in clinic when I get asked about this test is that the groups they studied, again, were only Parkinson's patients, only those they thought might have a risk for Parkinson's disease, and healthy controls. It did not look at mimics and try and compare them to Parkinson's to see if it was better able to tell Parkinson's disease versus Parkinson's mimics, which is really what we want to get to at some point. This trial did not do that. This was also tested only at one time point, and it was only designed to tell you whether or not abnormal alpha-synuclein was there. It was not designed to measure progression over time. So if I can use an example, it did not tell me you have 5 abnormal alpha-synuclein at time point A, and then if I test you in 10 years, you now have 100 abnormal alpha-synuclein. It is not designed to measure progression over time, which is something we ultimately need to get to as well. And then the last 2 bullet points, it's a lumbar puncture. We have a couple of tests that also can help us determine if you have Parkinson's or a Parkinson's-like condition. They're not invasive and not painful. So at this point, this is probably more of a research tool. It may have some benefit in the clinical setting, but I think less so at the current state. I will also tell you this actually created a lot of buzz in our International Movement Disorder Conference. There were a lot of people talking about this test, so I think you will hear more about it in the future. So I'm going to move into symptomatic therapies. The first one I want to talk about is CVL-751, or tavapadon. This is currently in an extension of phase 3, so again, please remember your phases. This is what we call a dopamine agonist, which activates dopamine receptors. There's currently several on the market, pramipexole or Mirapex, Requip or Repinerol, then a patch from called Retigotine or Nupro that some of you guys may be on or are certainly very familiar with. This activates different receptors, and so the hope is that you get the same level of benefit, but you don't have the degree of side effects. So there have been 3 phase 3 trials that have been done. One, I think, as a singular therapy, and I think the other 2 were add-on therapies. And we're hoping for results from all the trials later this year. There is a trial on IPX203, which has finished phase 3, which I think Dr. Espy is involved with. This is similar to Ritari, and it's actually made by the same company as Ritari. And what we found is it had better viability compared to the current Ritari, as well as regular levodopa. And the phase 3 trial showed an improvement of 0.53 hours of good on time compared to regular levodopa. And when I say good on time, what I'm saying is good control of your symptoms without what we call troublesome dyskinesias. Did I miss a slide? Oh, thank you. I'm going to hate this thing. Okay. So going back to what I was saying, thank you. Good on time is good covering up of your symptoms without the troublesome wiggling or dyskinesias that we see with medication. The last notification I've seen on IPX203 was a statement online from the FDA in July that said they needed more information, particularly on the carbidopa portion of the new drug. Then you have P2B001. This is also completed phase 3. This is a combination pill, and it combines low-dose pramipexole ER, which is a dopamine agonist, and rasagiline, which is what we call an MAOB inhibitor, which is an extender of levodopa in early untreated Parkinson's disease. And in the phase 3 trial, they compared a lot of different groups. So they compared the study drug, and then the 2 components of the combined study drug, so low-dose pramipexole extended release and low-dose rasagiline, and they also compared it to marketed pramipexole extended release at higher dosages, kind of what I would consider medium dosages, I think about 3 milligrams. And what they found is that the study drug, the combo drug, was better than its individual parts and was comparable to a higher dose of marketed pramipexole extended release. And then really interesting, while it was comparable in terms of benefit, it had less side effects, particularly problems with sleepiness and blood pressure drops. So I'm now going to talk about the vibration glove, and I can't tell you how many questions I've gotten about the vibration glove. So way as background, vibrating exercise machines have actually been around for some time. They've been around since the mid-1800s. Charcot, who's a pretty famous neurologist, developed a vibration chair for Parkinson's, and then one of his students, Tourette, if you've heard the term Tourette syndrome, that's where it comes from, developed a vibration helmet. And then we've had quite a few papers or review papers since then looking at studies on this. And I guess overall what I would tell you is the results are mixed. And the therapies to this point have not been superior to some of the medication treatments we currently have available. So the vibration gloves come from Peter Tass, who is at Stanford, and he developed these gloves to be used a few times a day for a few hours at a time. And the best way I can describe it to you is he's trying to reset the firing patterns in brain cells in Parkinson's disease. And to be honest, there really hasn't been a lot published on this. So there's a 2021 study which had 2 parts in fairly low numbers of patients. So the first part was a 3-month study in 6 patients, And the second part was 3 patients, one of them carrying over from the first part, in 6 months. And in each study, they had daily treatment with these gloves. And they had, honestly, pretty dramatic results. If you've looked into this and seen videos, this is coming from this trial. There were a lot of problems with the study, and I'm going to cite 3. One is the numbers are really, really small. If you think back to the phases that I talked about, we're hoping for people in the hundreds. Problem 2 is that patients knew they were taking the therapy. And really, it's mind over matter sometimes. People want to be better so badly, sometimes they'll get better. And then 3, I would tell you there's no comparative arm. So if you think back to the phase 3 trials, we really want to compare our new drug or new treatment to either an inactive drug or standard of care to really see if it works. And none of those things were done in this trial. So further data is really hard to find. I was actually combing through the literature trying to find something. I couldn't find a ton. There are 2 clinical trials right now looking at this further. One was done at Stanford and it's actually listed as terminated on clinicaltrials.gov. And the other one is being done at Oregon and started in July of this year. There's still somewhat low numbers, I think 36 and 30 respectively. They do now have a comparative arm, and they're calling it inactive vibration. So I think they're using vibration frequencies that are different from those they think are helpful for the Parkinson's brain. There were also 3 pending trials listed, 10 patients each, so again, very low numbers in early PD, more advanced PD, and then patients that have had some type of surgery from Parkinson's that isn't DBS. So this is a picture of the vibration gloves. I actually seen them in person. One of Dr. Barbu's patients actually flew out to California to be a part of one of these trials. As you can see, they very much look like research. Well, they very much look like they're in research, I guess. I feel like the main message I would want to relay to you guys is it's early. We need more numbers. And certainly if these are going to be available commercially, they need to be modified a little bit so that they're more user-friendly. So this is actually something I am excited about. This is a subcutaneous pumps. These are really meant for patients that would be a good candidate for DBS or for the Duopa pump. These are meant for people that are having motor fluctuations or dyskinesias and would be what I would classify as moderate Parkinson's or even advanced Parkinson's. Right now, there are 2 levodopa pumps being studied and 1 apomorphine pump. Apomorphine is a short-acting dopamine agonist. It's actually already available as rescue therapy here in the States in a shot form, and it used to be available in what we call a sublingual form where you could dissolve it underneath your tongue, but that got taken off the market. The first 2 bullet points are on the levodopa pumps. The first one is from Neuroderm. It's ND0612. And their primary study goal was to look at improvement of good on time. And if you compare to their comparative group, they have 1.72 hours of good on time compared to their comparative group. Again, that's good cover-up of symptoms without troublesome dyskinesias. AbbVie has also created a pump, which they're calling 951. In their study, they saw 1.75 hours of improvement compared to their comparative group. And then the last one is from Supernus, and this is SPN 830. This is the apomorphine pump. Their primary study goal was a little bit different, but for comparison's sake on this slide, I went to one of their secondary study goals, and they saw 1.97 hours of improvement of good on time compared to the comparative group. I would say all these trials have finished phase 3. There's a couple of things I've seen on the literature in terms of updates. With the AbbVie pump, they're wanting more information. That was of March of this year. And with the Supernus pump, I saw some notifications from October of last year. Unfortunately, this pump has been a little bit in limbo. It's a little bit frustrating, to be honest, because this pump is actually available in Europe and elsewhere and has been for a very long time. And it's always nice to have more therapy options when you're talking to someone about brain surgery or the Duopa pump. So I'm hopeful that these pumps will get on the market. I'm getting different messages from the drug reps. The hope is sometime very late next year, but we will see. This is a picture of what these things look like. So if you look on the left, this is an illustration of the Neuroderm pump. And on the right there is a picture of the apomorphine pump. I would say the big problems with these pumps in the trials is you can see where the tubing is inserted and people tend to get skin reactions around that site. So that would be the big negative so far from these pumps. I know we've had a talk on DBS, and Dr. Gerard highlighted some of these things, but I do want to mention some things that I'm excited about as well. So overall, the technology is continuing to advance. The older DBS technology, we could only create a circular electrical field around the activated contact. As Dr. Gerard mentioned, we now have contacts where I can send the electricity in all different directions. And what that means is I can really optimize your symptom control while minimizing your side effects. So it gives me a lot more options to give you the best outcome as possible. He also mentioned closed loop stimulation, and I really hope this is where we're ultimately able to get. So just to kind of repeat his same analogy, if you think about a pacemaker, the pacemaker is able to adjust in real time to your heart rate and control your heart rate, and that's where we want to get with DBS. So right now we have the ability to sense the electrons firing. We don't completely know what each electrical signal matches up to in terms of symptoms, but we've made a ton of progress, and I'd say we're pretty close. So we can match up certain electrical signals to your tremor, or your dyskinesia, or maybe your freezing, and then we can make adjustments in the clinic depending on what data we're getting. The hope is that the DBS can do it automatically and do it in real time. And so you don't have to come into the clinic. Your DBS will function at home doing the things that we're doing in clinic in real time. All right, I'm going to talk about disease-modifying therapy. So I'm citing a similar paper that Dr. Espe cited. There's a group that has been doing reviews of the different therapies every year since about 2020. They published this paper in June of this year, so this is pretty up to date. And using advanced search criteria, they found out that there's about 139 overall therapeutic trials. Out of those trials, 63 or 45% are disease-modifying trials. And if you look at the far right, these are the phases that those trials are in. So you see most of them are in the early phases. So you have 25 in phase 1, 32 in phase 2, and then 6 in phase 3. I want to pull out another statistic because I think it's really interesting. Out of those 139 trials, we're starting to look more and more at repackaging or repurposing drugs that are already on the market for other things. So one of the things we're looking at, for example, is diabetes drugs. And so if you look here, again, these are overall trials, not just disease modifying. You have a few in phase 1 and a few in phase 3, and you have quite a few in phase 2. So this really helps us because we already know the side effect potential and the safety potential of these drugs so we can move them through the clinical trial process quicker. Other statistics from this paper. So I would tell you in the last year, there's been 17 new disease-modifying therapies. The overall numbers that we're seeing with clinical trials is down a little bit from 2020, but the number of disease-modifying trials is up. So there is definitely an interest in looking at disease modification. So if you look here, in 2020, we had 145 trials, 39% or 57 were disease-modifying, and now this year we're at 139, so just a slight drop, but we're increasing the percentage of disease-modifying trials. So this is where the field wants to get. So disease-modifying therapies, just a couple of things I want you guys to really understand before we get into these. We do not know what causes Parkinson's disease. It's likely multiple causes, and likely multiple causes in the same individual, as Dr. Espy was trying to get to. We do know the end result is dying off of dopamine-producing cells and the presence of inclusions called Lewy bodies that contain this protein, alpha-synuclein that we've been talking about all day. The disease is likely a combination of a lot of different factors. So environmental issues, genes, they all play a role, and they're all leading to the cells not working correctly or dying off. So going back to this paper, because we don't know what causes Parkinson's disease, people are looking at a lot of different things. And so I don't want to run through all these too much, but I've put the numbers next to them in terms of how many therapeutics are being looked at. So inflammatory processes are certainly a concern. Cell therapies, which is pretty much stem cell, gene therapy, targeting alpha-synuclein has quite a few. That's still a great area of interest. The microbiome, which I think many of you are probably interested in, which is the composition of the gut and the GI tract, is still being looked at. And then what we call neurotropic factors, which are proteins and other things that might protect the nerve cells, are being looked at. And then finally, we lumped a bunch of therapies into the other category, which is there's quite a few of those as well. So trends that I would tell you, kind of just combing the literature, going to talks, we are looking more and more at people's genes and becoming more interested in gene-directed therapies. Not just genes, but also other processes that may affect someone's Parkinson's disease. We are trying to get more to precision medicine, as Dr. Espy alluded to. Repackaging of drugs, again, is a big interest for people because we can move through the clinical trial process quicker. And then we are still focused on decreasing and preventing the buildup of alpha-synuclein. If you remember back to that earlier slide where I had that review paper up, there were 6 trials in phase 3, and I want to go through those very quickly. So the first one is exenatide. This is a diabetes drug called a GLP agonist. We are finding more and more that diabetes is a risk factor for the later development of Parkinson's disease. And we're also finding that if you do have Parkinson's and you have diabetes, particularly if it's uncontrolled, your progression is worse and your symptoms are worse. So I would very much tell you, if you do have diabetes and Parkinson's, please control your diabetes as best you can. Insulin resistance in the brain does not mix well with dopamine cells. And so, again, we're looking at diabetes drugs to see if we can have some benefit. They did a phase 2 trial on this drug in a little less than 200 patients. They did a phase 2 trial and looked at motor symptoms over about 60 weeks. And they compared it to an active drug. And there was a modest benefit in this trial. They're currently doing a phase 3 trial which has a little less than 200 patients. And the results are hopefully going to be out in 2024. This is not the only GLP agonist that people are looking at. So I put in italics here. There's another one that's fairly far along in the clinical trial process called lexacenatide. Some results, preliminary results from that trial did seem to show this drug was offering some promise. And this was in about 156 patients. Butanetap is a drug that is going after alpha-synuclein. It reduces production of alpha-synuclein and several other neurotoxic proteins by kind of mucking up the genetics, so it messes with messenger RNA. It seems to affect the Alzheimer's protein as well, so it's being looked at in Alzheimer's disease and Parkinson's. They did a phase 2 trial where we saw fairly pronounced benefit in several different clinical scales, and they did compare this to inactive drug in that phase. Right now, they're doing a 6-month treatment trial, and hopefully we'll have results out sometime in 2024. The next one I want to talk about is a medication that is going after LART2. So this is going after people's genetics. We were actually involved in this trial at the Cole Center. This trial is what we call a LART2 inhibitor. We know that LART2 is a very common cause of genetic Parkinson's in people that are very young. But it also seems to have a role in people with garden variety, what we call idiopathic Parkinson's, which you guys have. So that abnormal mutations can affect your Parkinson's progression, can affect your prognosis. They did have a phase 3 trial in purely Parkinson's patients with this LART2 mutation. Unfortunately, we're not getting enough patients, and it was discontinued. So now they're moving back to enrolling these patients in a phase 2 trial they had going with people with and without this mutation. So this one's actually going to take a little bit longer. Ambroxol is a respiratory medication. It breaks up phlegm. It's been on the market for a long time, so this is another one of these repackaged drugs. This seems to affect a mutation called GBA. GBA mutations are a very common risk factor for Parkinson's disease. And what happens when you have this abnormal mutation is you build up this abnormal protein, which seems to interact with alpha-synuclein and can cause Parkinson's disease, and typically has a worse progression if you have this mutation. They have done a small phase 2 trial of this with 18 patients, which showed safety and some benefit. This was not blinded, but the data was good enough for them to move forward with the phase 3 trial, which is beginning. So lactobacillus prebiotic-probiotic combo is also being looked at. They're looking at a trial where they're comparing this prebiotic-probiotic as an add-on to levodopa therapy. So some will have it as an add-on, some will just have the leave it up with therapy, and they're looking to see whether or not there's a benefit here. This trial is not blinded. Two other ones that are listed that I'm not going to really talk about too much is memantine is a medication for cognition. It does seem to potentially slow down the spread of alpha-synuclein from cell to cell. Then Chinese mushrooms, which are protective for cells, are being looked at as well in phase 3. So I'm going to talk about alpha-synuclein therapies for a little bit. I'm going to have a slightly different opinion from Dr. Espy, although we agree on a lot of points. Normal alpha-synuclein protein is seen in the brain and nerves as well as many other tissues and organs that you've seen. In Parkinson's disease, what seems to happen is it changes shape and it clumps. The prevailing theory is that's bad. They've done numerous studies in animal models where abnormal alpha-synuclein is negatively infecting animals and in cells. So there's a lot of evidence to support that. But he's right, it doesn't carry over well to human trials. Butanetap, again, is in phase 3 and does seem to have some promise. I wanted to mention a couple other ones that are out there. UCB 0599 is being studied in a collection of trials called the Orchestra trials. This is something the Cole Center has been involved with as well. This is an oral inhibitor of the misfolding and clumping of alpha-synuclein. It's currently in phase 2. At our big international movement disorder conference, I went to their study meeting. They seem to be pretty excited about this. They're already thinking about phase 3. We'll just really have to see what the data shows as the trial finishes up. Prasinezumab, which is from Roche, had some disappointing results, unfortunately. This is an antibody that targeted alpha-synuclein using IV infusion. The results came out last year of their phase 2 trial called Pasadena. This was done in early Parkinson's patients, and it did not meet any of the study goals, none of what they call their primary endpoint or their secondary endpoints. But when the company looked at the data, it held enough promise for them to continue to study this drug. So they're doing another phase 2 trial called Padova, and this is actually also being done at Vanderbilt. So if you do have some interest in this, it's somewhat local to get involved in this trial. I put italics in the bottom that Siponimab is another antibody similar to this. This also did not have good study results. Actually stopped this trial early because it was not showing any promise, even at a midpoint study analysis. The last one I want to mention is UB312. This is a vaccine administered in the muscle. This has finished phase 1. It does seem to be meeting its study endpoints so far. It's safe and well tolerated. It also made the appropriate antibodies and appeared to have what we call effective target engagement, so it got where it was supposed to get. But Dr. Espy is right. We have not had any trials on alpha-synuclein that have met their study goals in phase 2 and moved to phase 3, with the exception of Butanetap. Potential problems: we're treating individuals too late. The damage is already done. Problem number 2, alpha-synuclein is not the main issue or is only part of the issue. Alpha-synuclein changes may be a byproduct of something else going on, and when we reduce alpha-synuclein, we're not getting at the underlying problem, so we're not really helping anything. And then option 3 is the trial designs are not good enough or the trials are not long enough to really show a response. I do think there's some hope, and this would be debated in the neurology world. There are now 2 FDA-approved medications for Alzheimer's disease that attack their protein, and there's probably a third on the way that's showing really good data. In the neurology world, this is a very, very, very hotly contested topic. There are a lot of people that don't think the data is good enough to progress, but it was enough to get through the FDA, and there are certainly people in a lot of different circles that are very excited about these drugs. I do think there's maybe something here, and certainly it may be something that we can carry over into the Parkinson's world as well. Nilotinib. So this is a chemotherapy agent for leukemia. It affects a protein called C-Abl kinase, which appears to be overactive in Parkinson's disease. This had a lot of benefits in Parkinson's in preclinical trials. It had additional benefits for Parkinson's in a very small trial with Parkinson's and dementia with Lewy body patients. And the results are fairly dramatic, and this really got a little out of control. The national media got a hold of this. There were a lot of people coming to me a couple years ago wanting to get on this drug, and we just didn't know. And so since then, we have done 2 phase 2 trials. One showed poor target engagement, so it didn't get where we wanted it to get, and it also actually worsened motor symptoms. And then another trial showed it did get where we wanted it to get. It had good target engagement, but there was really no change in motor symptoms in these trials. So that kind of killed nilotinib. But the protein, or the idea behind it, does seem to have some merit. And so there's actually several studies right now looking at c-Abl or targeting c-Abl kinase, which are in phase 2, and you can see those listed there below. I don't think I have enough time. I think I'm running low. Yes, I am. Okay. I have a couple slides on gene therapy and cell therapy. I don't want to say too much with it just because I'm running low on time, other than to say the trials are early. The results have been fairly mixed, and we still need to kind of iron out a lot of kinks. People are still looking at this, and if you are interested in stem cell, there is an actual international group or international consortium called G-Force PD that is working to iron out those technological kinks and see if we can get this to the market. I get asked a lot about stem cells. I guess what I would tell folks is, if you're interested in this, by all means, get involved in clinical trials. Please do not go and get commercial stem cells. What happens is that these places pop up intermittently. They're there for a couple years, people lose their life savings, and the next thing I know, they're getting shut down and moving somewhere else to do the same thing to another group of people. It has some merit. We're not there yet. If you want to get involved in it, get involved in a clinical trial. Do not go to some office down the street that's reporting that this is your end-all be-all for Parkinson's. This is a scam, if that's what's happening. So my conclusion statements: Parkinson's disease is not a singular disease, and you've already heard this. This is a syndrome. This is caused by multiple interrelated factors that are probably different in each individual. We really need to move more to what we call precision medicine, where we're treating the person as a person and not as a Parkinson's disease patient. I have been saying this for years. I've asked this at our conferences. I think, for me, the main thing we need to do with disease-modifying therapies is we need a cocktail approach. We don't need to target a singular mechanism. Oncology was already mentioned as something to look to. This is what they do in oncology. They target a lot of different mechanisms in each individual, and I think this is where we ultimately get to. If I can offer you encouragement, research is increasing. We are making progress. People like Dr. Espy are great because they're always asking us to take a step back and make sure that we're on the right path, but we are making progress. There is hope. Genetic testing, I think, is going to be the way of the future. There are several ways to get free genetic testing now. If we're talking about precision medicine and treating people as individuals, genetics is one way to do that. And then I would encourage you to get involved in clinical research. We need people to continue to develop our therapies. I've heard some disturbing statistics. I've heard statistics that only 1% of Parkinson's patients are involved in clinical research. There are a number of trials that shut down because they don't get enough people, or they get delayed because they don't get enough people quick enough and they don't meet their time point or endpoints. And we've already seen it takes 10 to 11 years to move from phase 1 to the market if we're successful. So we've got to speed this up if we can, and you guys are the ways that we need to do that. So get involved. One of the ways I tell people to fight back is to get involved in clinical research. So there's various places that you can go to do that. Clinicaltrials.gov has been mentioned today. You type in your disease, you can type in your location, they will tell you what's going on nearby. Michael J. Fox Trial Finder is another place specifically for Parkinson's trials, and same thing, you can find out what's nearby, contact information to get involved in these trials. And the last thing is, this is a real passion of mine. I want to build up a big research program here for you guys to get involved with if you would like. We try and keep our website updated, and we do have a research tab on the website. We are in a lull right now, but we'd like to have 4 or 5 trials at minimum going if we have the manpower. So again, we're hoping to have this available for you guys in the future if you want to get involved. So that's it. Thank you. I think I'm, sorry, I'm actually got a mic on. I think I'm right on it, so I think we're going to do our Parkinson's hack presentation. I think they're coming up here.
Is this yours?
Yeah.
Gaffed and everything. Wait. Great, Google.
It's okay. It's all right. I'll wait till after.
Now, this is yours?
No, that's
Yeah, just like that. Some of your stuff.
Oh, really?
Yeah.
Zach, you ready? All right, so one of the things that we got feedback on last year was that people really wanted to know everyday hacks, and we also asked a bunch of questions of people in the community about what types of hacks they would want to know or what questions they had. So we're going to attempt to do that. I have some pre-prepared questions. But first and foremost, I want everyone to introduce themselves. I've got Martha Pack, Zach, and then the Walters family. So if you guys want to briefly introduce yourself.
Can you all hear me? Oh, okay. My name is Martha. I am an occupational therapist for 30 years. Can't believe it. It's gone by quick. I started my own business during COVID because I thought I was going to get laid off. But I decided to become a bridge between a contractor and a patient to do home modifications, because I would go into homes doing home health services. People spend thousands and thousands of dollars to remodel their bathroom, but then they can't access their shower because it wasn't customized for their needs. So that's where my business started, called Adapt and Stay. But it's kind of morphed into other things. So I've enjoyed this journey. It's considered an outpatient Medicare Part B service, so it's covered by insurance, or it can be with a doctor's order, which I have gotten good referrals. But I also am a certified dementia practitioner, so I do also specialize in that as well.
I'm Zach Guza. I run Black Dog Fitness. At Black Dog Fitness, we have rock steady boxing, spin and stretch. We have Tai Chi. We have power classes, and we have what else am I missing? Fun. Thanks. Good. Yeah, we do that some, and exceptional jokes. Yeah. All right. Thank you. What? Nobody asked.
We are Mike and Lori Walter. You don't care. This is Goose. We've been asked to share some hacks that we have as far as having a dog. By the way, Dr. Barbu, you're not my hero anymore. Dr. Zayas is not my hero. With the medical advice, get a dog. We train service animals, and we do them mostly for children in need. And this, of course, is a service animal for Lori. But it can be your household pet that can make your life just a little bit better every single day. Make it worse, but we're going to go with the positives and say make it a little bit better. So we've been training dogs obedience for 35 years, doing service dog training for about 8 years. And Lori's only quiet because, God bless her, she's recovering from surgery 6 days ago. So get out there and do some boxing or something. So.
Thank you guys for being here. I didn't know that. All right, Zach, the first one's for you. The question is about freezing. In your experience, what can be done about sudden freezing?
So sudden freezing, when you just kind of come to a stop, my dad used to say it felt like he was stuck to the floor, sticky feet, and it can happen just boop, all of a sudden, or it can get into that festination, those itty bitty bitty steps. We say we have the 4 S's. I've added a 5th, an optional 5th, but the official 4 S's are to stop. So don't force. If you're freezing, don't force it. Don't just keep, because it's going to push you over. You sigh. So the second S is sigh. Just take it easy. Reset, reboot, and then shift. Shift your weight. So take it over to one side. So stop, quit forcing it, settle down, shift to one side, and then take a big step. Knee comes up, take a big step. My addition is to stop and swear, and then take a sigh, and then shift your weight and take a step. There's a lot of tricks, whether you swim through it, whether you shift to the side, but those 4 or 5 are really kind of the base of how to get through a quick, instant freezing moment.
Thank you. I would say from a medical professional standpoint, if you have a walking aid, one of my common strategies is to hang a tennis ball down or a ribbon and walk into it. If you can get pretty fancy if you want. There are definitely laser walkers and things like that, but those are simple things you could try as well. Mike and Lori, this is the one for you. Knowing pet therapy is very specialized. How can service dogs specifically assist those with Parkinson's? And what is the difference between a service dog, a therapy dog, and dogs for emotional support?
Okay, let's start with the top of the chain, and that would be a service animal. A service dog is specifically, can you hear me without this? Wave in the back if you can hear me. Cool, we'll use this. Goose will be available when we're done if y'all want to come up and see him. A service animal is specifically trained to perform a task to make everyday life possible or easier for someone. So he has to do something that everyone else can normally do without him. Parkinson's, that's a horizon. What he does is he provides mobility, stability, and now he has to be trained to do it under 4 circumstances. Just him. He has to be a shopping cart, a walker, or something he's not familiar with. And that means he has to be put in a position. The reason he does that, or the reason he can do that, is he is trained to lay there when I whistle at him. You know. He's trained that wherever Lori moves this stand, he has to be in a specific place. This way, if God forbid she falls, he can react. You don't have time to tell him, hey, you got to get underneath here. He just knows. She's never hit the ground while he's been with her, so that's a positive. There's a lot of other stuff. I know we don't have a ton of time. A therapy dog is a dog trained to help other people. You actually have to go through a certification. You see him at UT Hospital, you see at Children's Hospital. He is cross-trained. He does therapy work for the Blount County Sheriff's Department and their 911 team. We do East Tennessee Medical Group. We go visit patients. We go visit nurses and doctors. So he can do that. Then there's emotional support dog, and that is legal definition of an emotional support animal is your certified mental health specialist has determined that that's going to be part of your treatment. In order for you to function and move and live and go about, you need to have this dog with you. And now it is a dog. You can't have a snake, a peacock, a gorilla, or whatever anymore. But here's what I'm going to tell you. If you got a dog at home, you got an emotional support dog for yourself. Go home. There are so many things you can do that are going to affect everything we've talked about here today. We take the dog and we just go to the park. You know, we don't want to go to the park. We get some exercise. I'm looking at his watch already. So, if you have, and we can go over this after the side. But if you have a dog at home, I'm telling you what, you've got an emotional support dog.
Thank you.
Sorry.
I honestly don't know this much or that much about this. Walter's actually going to speak at one of our Cole Series sessions. So if you guys are interested in knowing more, that is an opportunity.
December 6th, we'll be doing one of the sessions.
So we didn't have enough time to highlight them as much as we wanted to. So, okay. Martha, from an OT perspective, what are some of the best known everyday tools that not everyone thinks about when dealing with some of the symptoms of Parkinson's? And if you could pick only 3, what would they be?
Yes. Well, picking 3 is really hard, but I will do my best. I would categorize to try to make it 3. So for one of the biggest problems I see is self-feeding, sometimes with the trimmers. Food spills and gets everywhere, and it's frustrating. So I do like to add a plate guard. You just clip it onto the edge of your plate, and it helps you scoop the food. And in holding with the food, you can use a weighted utensil. The weight gives your arm stability, and you can bend the spoon. I'll switch hands. If you're having difficulty, you're not quite able to reach your mouth, that little bit of bend, and they make these specifically where you can buy them where they bend easily. This is a whole set where you've got everything, the fork, a rocker knife, and a spoon, 2 different spoons. And then as well as the cup, a lidded cup with a handle that's lightweight, because your liquid will make the weight. But the handle makes it easier to hold, and the lid keeps things from spilling. This is a Tervis cup. You can get them on Amazon pretty cheaply, but that keeps your either hot or cold. And then you can also build up utensils if you don't want to. You can use this stuff for anything, for toothbrushes, combs, hairbrushes, to build up the handle to make it easier to hold. And you just cut off the amount that you need. And then the other thing would be a hip kit. It's what it's called, usually for hip patients that have had a surgery. But the biggest thing in the hip kit, of course, that everyone loves is the reacher. Some people call it their angel, because you don't want to overreach and lose your balance with things. You want things close to your environment. And this helps you, pick things up either high or low. so that you don't have to stand and do that. A wonderful tool I also love is the leg lifter. This is about $11. You can also use other things besides buying one of these, but the nice thing about this one, it has a handle so that it'll stay on your wrist if you can't hold something else. It's like a dog leash without the dog, but you just put your foot in and you lift over the tub, or if you have a seat in the tub, or you can use it to get in and out of a car or on and off a bed, all kinds of things. My favorite hack, I have to bring it, is the pool noodle, 99 cents. They're all on sale right now. I like to use this actually as the cheap leg lifter. You just, so, many other things. I like to use it for exercise. You can stretch. You can do so many things. I want to write a book, 101 Things to Do with a Pool Noodle. It's probably already out there. But you can cut off what you need, and you can also use that like to hold a deck of cards. You can just cut, to hold it if it's hard to hold a deck of cards. So many fun things with this. So, the best thing too, which this is not original, all therapists know this. To prevent falls out of the bed, you can stick this under a fitted sheet along the edge of the bed. So it's kind of a bumper for adults to warn you that you're close to the edge and hopefully not fall out. Okay?
Thank you. We're desperate for those types of things. Zach, question number 2. Exercise is discussed every day and is proven to benefit patients with Parkinson's. In your opinion, what should patients not do? And if they do exercise, what would be the best exercise for Parkinson's?
Could you say that? No.
To do and to not do.
To not do. So what we don't do, exercises we don't do, at least at the gym, are anything that hurts and anything that's dangerous. I mean, I think you could pretty much apply that to anything through life. If it hurts, it's probably not a great thing to be doing. If it's dangerous, it's probably not a good thing to be doing. We don't walk backwards in terms of an exercise. It's not worth it for walking backwards. We don't cross legs. Anytime like crossing leg to move sideways, it's just you get caught with your legs crossed. There's really not a lot of options other than fall down. And that rapid standing, a quick whoop pop up, is with the blood pressure concerns, that could be pop up, fall down, unconscious. So those are things to just avoid on a regular basis, walking backwards, crossing your legs, and standing up quickly. In terms of just straight plain old exercise, like an exercise regime that I would avoid, bodybuilding. If you've got muscles that are already moving uncontrollably, I wouldn't make them any larger. That doesn't seem like a great idea. And CrossFit. CrossFit needs to be heavily modified. I wouldn't just walk into a straight, regular, plain old CrossFit gym. It needs to be well modified. So in terms of the best exercise to do, it's exercise that you're going to do and you're going to keep doing. Whether that is bodybuilding, why did that come into mind? Boxing or walking. If it's something you're going to do regularly and do enough, that's what you need to be doing. So that's the best I got.
Yeah, I'd echo the any exercise that's safe is good exercise. So if you find something you enjoy, that's the best exercise for sure. Mike and Lori, I've got 2 questions for you. I have one prepared and also one from Dr. Zayas. He just came up and grabbed me.
I don't care what you got. What do you got, Doc?
He wants to know what breed you'd recommend.
Breed that we recommend. Before I do that, I'm contractually obligated. Okay, I have to do this or Goose will not listen to another word I say. If anybody has bacon, I'm doing it. Okay. Believe it or not, breed does not matter. I like this thing. Can I have this? I do this at home. Breed does not matter. Obviously, in a situation like this, where he has to be able to be strong enough and big enough to either keep Lori from hitting the ground or from supporting her. The other thing he's trained to do, if she is on the ground, he's trained in 3 different ways to get her off the ground. So there, you talk about size matters. As far as after that, it can be anything. It can be common small dogs are, let's say, diabetes notification, PTSD, seizure notification, where a dog is monitoring a person's blood pressure, they're monitoring their breath, they're monitoring whether they're sweating or not, then it doesn't matter. And we're going to stop there because there's a lot of ways to tell if a dog is not a legitimate service animal. But like I think Dr. Zeiss actually said, some of the smarter breeds are going to pick it up quicker. Other than that, no, it does not matter what type of dog.
Okay, that's helpful. I know you're speaking for us in December.
Yes, sir.
The question was, if you had 2 top takeaway points for what you may be talking about in December, how can you get people excited about your talk?
One, it's hands-on. We just don't have the time. Goose is trained where I could actually release him in the crowd. There's questions I have to ask first, so we're not going to do that. If you want to see him afterwards, great. So you get to put hands on him. You get to see what he'll do. We'll show you how he performs his. He has 40 commands. We'll run them all if you want. So that would be one. It's a lot of fun. The other 2, not here today, and that's Blueberry. Blueberry's about this big and blue. And she's the cutest thing you've ever seen. She's a therapy dog we've trained specifically for children. So she comes to it, to the presentations we do. The other thing will be a little bit of etiquette. I said the last time I'm doing 3, I'm sorry. Would be etiquette around service animals because it's critically important to act accordingly around someone who has a service animal.
Thank you.
Yes, sir.
All right, Martha, last one. Safety at home is extremely important. What is the first step in making sure your home is set up and properly equipped from a safety standpoint in the Parkinson's world?
Well, that's a really good question. So I usually go in, I call it eagle eyes. I know what to look for that are red flags where you may think your home is safe, but it may not really be. And I'll look at the here and now, and then I'll also project for the future, as a disease can progress. So some really quick and simple things, you remove throw rugs, any cords, clutter, children's toys, make sure there's a clear pathway. Night lights are always good, and make sure there's good lighting. Layered lighting is really good. How these, this I thought it aimed up. Well, there's layered lighting a little bit there. 2 or 3 different kinds of lighting is important. Contrast is good. If you kind of squint your eyes, and most showers have like a little threshold, it all looks the same. But if you put a little piece of tape on that threshold, that really will stand out to make sure you're not going to trip over that. And of course, adding grab bars is super important. Permanent grab bars, not suction cup grab bars. Those fall off and can make you fall. There's so many things. But those are probably the top highlights. Also, any durable medical equipment that's needed, whether it be a shower chair or a shower stool or a sliding tub transfer bench, swivel sliding tub transfer bench with your seat. Whether you need a Hoyer lift or, if you're at that point where you need a ceiling lift where you can track going from the bedroom to the bathroom easy on the caregiver without a lot of heavy lifting. There's so many detailed things. Making homes smart is a big technology. An Alexa is a great tool. It's fairly cheap and affordable, but Alexa can remind you of your medication reminders. You can call people if you fall on the floor. Of course, you could also get the life alert system, but it is a subscription that you pay. But we want to prevent falls at all costs if we can. And for my husband's sake, who was a volunteer fireman, we always want to check your smoke alarms. And October is change your smoke alarm batteries while you change the time. Or is that November now this year, I think, actually. And then also I will just add a little piece about dementia can also play into the part of Parkinson's. And adapting your environment for dementia, like I said, the here and now, as well as when it may progress, to prevent wandering, all kinds of falls. Like, we don't want them going downstairs into a basement, that if that's not safe, if they're in a later stage of dementia. So lots of things to look at. You're welcome to talk to me afterwards, and all of these things can be found on my website if you're interested. But thank you for having me today. It was a pleasure being here and an honor to be asked to speak.
Well, thank you, guys. We have to be out by 3. There's another group coming in. I think our panel, okay, staying up for a little bit. The presenters will be available, but we have to get out by 3, so maybe next 10, 15 minutes if you have questions. Thank you again to all you guys being here. Thank you. I really hope it was helpful. Please thank Paige again. She did a fantastic job. Thank you to all our speakers again, Dr. Espay. Thank you to all the Cole people. Thank you to our panel. Hey.
Out of time, I really thought you were on my side, and now there's nobody on my side.
Oh, sorry? Oh, no. I just gotta take back the mics. Yeah.
Said I need you right now.
Sorry, really quick, if anyone filled out the evaluation form, you can drop it off with Laura at the desk right outside. I think she's sitting on, come out the door, she's on the right side. Thank you.
That you'll be here when I need you the most. So don't let